आपका नाम क्या है? लक्ष्मण?
सर लक्ष्मण शिवांक राहुल।
नहीं ये तो पता, आप थम्स अप करोगे तब मैं बोलूँगा। Hi, good evening everybody, and welcome to these deliberations once again. We are live here today to discuss about obstetrics and gynae, the important stuff just before the exams. And as usual, I've tried to get some questions which are absolutely essential, some questions which came in the recent exams, and there are still some controversies which are going about them. So I thought I'll clear all of them for you just before the exam. And as usual, you're most welcome to send in your queries when we are discussing this. And it'll be great if you limit your queries to just a couple of lines so that I can read it fast and try to solve it as I'm doing this session, all right? And I hope all of you do very well in your exams, and stay interested in reading and stay interested in preparing. I know there's a lot of information coming your way. There are many institutes, and you are coming to the best institute possible to get the information. But remember, even if you're getting tired, make an attempt to stretch that last mile, all right? You're just about to come to the last leg of your preparation and just about to give exams. So don't give up just yet, all right? All the best, and we'll start right away with the questions which are very important, okay? Right, I'm audible, all well? Okay. So we'll start with the first question here, and that is a little bit about the abortions since the MTP rulings changed recently. A pregnant woman at 14 weeks gestation came to the outpatient department for a medical termination of pregnancy. How much dose of Mesoprostol is to be given to this patient? Now, when it is 14 weeks of gestation, things change a little bit. All of you know about the regular medical abortion which we know, which is done till 7 weeks in India. I mean, it's approved for 7 weeks and 9 weeks overall. So when we say 7 weeks and 9 weeks, we know that it is going to be 99% successful and 95% successful if we do a medical abortion. So when we do in the first trimester, when we do, we are using mifepristone, something like 200 to 600 milligrams. You know, mifepristone is a antiprogestin that is going to kill the fetus, and then we use the Mesoprostol. Around 24 hours to 48 hours later, we will use the Mesoprostol. Now, this Mesoprostol is mostly given vaginally because we give a good high dose of 800 micrograms there. So that is the dose which is giving in the first trimester. Now, the question is at 14 weeks, that is the beginning of the second trimester. Most of us take second trimester beginning after 12 weeks. So at 14 weeks gestation, how are you going to do the abortion? So understand that the dose of Mesoprostol, when the uterus is small, it can be as high as 800 or sometimes we say 600 to 800. But when it is post 12 weeks, we start reducing the dose. And after 24 weeks, we reduce it still further. So I would tell you now, the Mesoprostol to be given here is 800 micrograms, because the only thing we are giving here is Mesoprostol. Now let me explain this a little bit more in detail. So when we are using for 14 weeks, when we are using the combo, just like what I said here, remember I told you the medical abortion which is done for a patient who has come to you in the first trimester, and we are doing it till 9 weeks. For that, we are using 200 mifepristone and Mesoprostol 800. So when I am using a combination, that is at 14 weeks, if I am using a combination, then the mifepristone is 200 still, but the Mesoprostol becomes 400 micrograms, all right, and that is given 3 hourly into around 5 doses, up to 5 doses you can go. And when using Mesoprostol alone, which is the question which has been asked now, that is 800 micrograms. And I would always say give it vaginally. See, orally, whatever Mesoprostol you give, I mean, it is not that we don't give orally, but I have seen a lot of side effects, you know, the GI side effects of vomiting and a lot of cramping and diarrhea. So I would prefer that we mostly use the vaginal route. So that's the answer for this question. We'll go up to the next one, and answer A, yes. PrepLadder app is not available on iOS. I think we'll keep all those queries for some other time. We'll stay relevant to the questions which have been asked here, right? So I know it's a concern these days, but I'm sure the team will listen to this and they'll respond. So I'll respond to the questions which you sent to me. What type of fibroid is shown in the image below? Now, this image is surgery which we are doing around 3 months back, and if you can see, there is this big mass here. This is obviously the uterus. I can show you the uterus here. This is the fallopian tube. I'm marking with red here. Let's see, maybe this will show you better. See this one, that's the fallopian tube here. So this is the uterus, but there's a fibroid here and there's a fibroid here. So I'm asking you the one which has been marked with the artery forceps here. So what is this fibroid here? So yes, you can see there's a peduncle here. So this is a subserosal fibroid. They keep giving you these pictures in the exams these days, and you must know the FIGO classification of fibroids. That's been almost a routine for the PG entrance exams, and even the MCI students have been asked a couple of times about the location of the fibroids. So I'm not going to go into great detail of every type of fibroid, but always remember that the fibroids, they start intramural, always start intramural. So start understanding this by remembering that the type 4 fibroid, is the one which is every part of it is inside the muscle. So when that type 4 fibroid is the place where it starts, the uterine contractions will try to push the fibroids outwards or inwards. So if the fibroid goes inwards or outwards, the numbering changes, the category changes. So if it is coming here, then we say it is 3. If it is coming a little bit into the cavity, it is 2. It is too much in the cavity and just partly in the muscle, it is 1. And if it is hanging from the cavity, it is 0, or the submucosal then and pedunculated. And the other end is that it will be going towards the serosa 5, going to more towards the serosa and less in the muscle, type 6, and hanging out like this, subserous pedunculated, the one which we are discussing here. Okay, and the type 8 is the cervical fibroid. So, and a quick revision of what you have to know these days, and don't try to turn the pages when you see these classifications, because all these classifications and the pictures which are given in your books have certainly taken the interest of the examiners, and they are asking you a lot of these classifications, and if it is in the book, it can be asked. The rule is that if it is in the book, the standard book, which I always say it's Novak Gynecology and Williams Obstetrics, but now you don't like me for saying that, I know that. So you can go to Shaw's Gynecology and maybe Mudaliar Menon Obstetrics, or you can go to even Holland and Bruce Obstetrics books. So these are very good Indian books, and the Western books also edited by Indian authors. So read these books and you can get the answers, and if you have doubts, then you can always write back to me on the PrepLadder forum. But Novaks and Williams will give you the best answers, and a lot of people are following these principles now, and the confusions are reducing. Okay, so which type of fibroid is shown here? It is the subserosal fibroid. I'll show a couple more. They've asked you a question once, which type of fibroid is most easily removed by doing a laparoscopy? So if I'm doing a laparoscopic myomectomy, obviously the ones which are more, if I'm putting a laparoscope here and doing a myomectomy with my laparoscopic instruments, so type 7 and a type 6 and a type 4 or type 5 rather are the ones which I can take out easily. Yes, if you're experienced and you have the laparoscopic skills, then a type 4, yes, we routinely take out type 4s also laparoscopically, but then that's a difficult one. You should be an advanced laparoscopic surgeon to do that. So for your purpose of your answer, the easiest removal of a laparoscopic fibroid, laparoscopic myomectomy for a fibroid is the type 7 or a type 6, maybe even a type 5. Okay, so I'll show you some more. So what is this? I'm showing a hysteroscopy and I'm trying to show you a lesion here. So if you can see this lesion, can you tell me what is this lesion? This is a firm looking mass which has got well circumscribed margins, and you can see it is standing away from the uterine wall behind. So this is a submucosal fibroid. Okay, this is a type 2 fibroid, type 3 to type 2 fibroid, because you're not able to see the lateral margin here. See, you're not able to see the lateral margin here. So you don't know how much of the extent is inside. So it was mostly a type 2 fibroid, and maybe it was mostly in the cavity if I had shown you the lateral end. So easy to take out fibroid on a hysteroscopic myomectomy is the type 1 and a type 2. Okay, yes, I will always say type 0 is no discussion. Type 0 is the easiest. Type 1 we can do easily. The one which is here is looking like a type 1, and yes, a type 2 some of us can do them. Some people would say it is not very safe. So type 0 histoscopically, look here once more, type 0 histoscopically is easy, and type 1 is also easy. Type 2 some of us, type 3 definitely not, don't even think of doing it histoscopically. Okay, so type 0 and type 1s are the fibroid which can be taken out histoscopically. Please do find time and read about the media which is used for the distension of the uterus for the purpose of doing a surgery in a histoscopic method. So the media which we use is mostly the normal saline to distend the uterus, because I have bipolar instruments. But if I have unipolar instruments, then I will have to take the solutions which do not conduct electricity. So I'll have to use things like glycine or dextran or sorbitol. These are the things which I use for unipolar current. So do find time and read about this, a little bit about the media, how much you can give safely, and how much is the alarm time and how much is the stop time. Do find time to read those things also. So let's move on and see another fibroid. Can you see which part of this picture is a fibroid? You know, that was a question somebody asked me. So yes, this is actually the uterus, is a specimen of a hysterectomy done in my hospital, and of course the tubes were here but they've been removed, so they are in the other part of the specimen. So this is the fibroid, and there is a huge fibroid here, if you can see, and in fact this is the cervix here. So yes, what type of fibroid is this? Yes, it is all around the cervix. So this is, yes, a okay, yes, cervical fibroid. Yes, I am getting the answer which I want. So yes, it is a cervical fibroid. Okay, this is a cervical fibroid, and it is encompassing the whole cervix. Now this fibroid, which is so huge, a posterior cervical fibroid, if you can see, because the cervix is pushed forwards. So if there is a posterior cervical fibroid, that is the one which can actually go and cause urinary retention, because see, this is the uterus, this is the vagina, bladder anteriorly, and pubic symphysis. So if there is a fibroid which is here, if you can see, posterior cervical fibroid like this is going to distend so much that finally it is going to push the uterus anteriorly. It is going to push the uterus anteriorly, and that uterus is going to press the bladder neck against the pubic symphysis, and that is going to cause a urinary retention. So that is one question which has been asked to a few people, that which fibroid can cause retention of urine more easily than others. So that is the posterior cervical fibroid, and this is that posterior cervical fibroid. Now this appearance, I mean, it's very interesting, you know. It was right from my third year of MBBS, I've been taught that this is the cervical fibroid, and it looks like the lantern on the dome of St. Paul's Cathedral. We all should know where is St. Paul's Cathedral first, and we should know there is a lantern on top of that, and we should know the shape of that to correlate well. So thanks to the Google images, of course this is from the internet. So try to imagine this and look at the lantern here. Okay, this is the lantern here. So yes, it looks like that, I feel. I mean, if you have a very good imagination, but you know, every time they said the lantern, and I was thinking of the lanterns we have in India. So it did not match too much with that. So yes, if you see this picture, it somewhat matches the very famous description given to the cervical fibroids. Okay, so that's the cervical fibroid. Now this is a placenta which was delivered around 6 months back in my hospital. Can you tell me what type of placenta is depicted in this picture? Velamentous insertion? No, this is not a velamentous insertion, because in a velamentous insertion the placenta and the umbilical cord will have a relation somewhat like this, that the umbilical cord will split into its vessels much before it is entering the placental margin. So that is a velamentous. Normal placenta, well, I'll keep it on hold. Circumvallate, yes. Battledore, no, because battledore is a cord which is attached on the side like this. Battledore is also known as the marginal insertion. So yes, this is not a marginal or battledore. This is not a velamentous. Now normal placenta and circumvallate is a problem here. So normal placenta won't have this whole lot of membranes, can you see, which are folded on the sides. See, if you see this picture now, this is the whole lot of membranes which are on the periphery of the placenta. So try and imagine that if I try to show you with my hands here, that suppose this is the placenta and these are the membranes. So they are like this, the placenta and the membranes, the chorion and the amnion are like this, you know. So this part is attached to the uterine wall. So now the placenta, the chorion is a little small. So when the chorion is a little small, the membranes are just as big as they are. So the placenta is small and the membranes are now all over the periphery of the placenta. So a small chorion and a big amnion will make this circumvallate type of a placenta. All right. So let's move on and see another question. A patient presented with secondary amenorrhea 3 months post delivery. Before surgical intervention is considered, which of the following can be done? Secondary amenorrhea 3 months post delivery. Yes. What comes to your mind first? That is, if a woman is delivered, then she would not be having any periods naturally most of the times because she is breastfeeding. That information we don't give in the questions most of the time because we want you to think the obvious first. The obvious is that she is breastfeeding the child. Yes, we don't have to induce an OCP to induce a cycle right now because you must find out if she is breastfeeding. Please remember, OCPs to induce a cycle is a crime here because we all know that if you give combined pills when a woman is breastfeeding a child, it can stop the breastfeed from coming out. So pulsatile GnRH to stimulate the ovary, progesterone to give withdrawal bleeding, all that is not done. Just assurance is enough. Reassure the woman that you're breastfeeding, that's why you're not getting periods. Now how does that work? We know all very well that the hypothalamus acts on the pituitary to make the FSH to make the follicle grow and the LH to make the follicle rupture and make a corpus luteum, and the estrogen and the progesterone makes the endometrium proliferate and secrete respectively. Now this is what is the normal menstrual cycle, and we had a big discussion about this on the app, almost 2 hours, 2.5 hours of discussion of the menstrual physiology. Please do find time to read that because that menstrual physiology, if you understand well, then 70% of gynecology becomes very easy to understand. So that part is clear. So let's see what happens in breastfeeding. That the oxytocin increases to make, the prolactin first we'll discuss, it increases to make milk production, and the oxytocin is required for the, milk letdown. Now this high prolactin throughout the pregnancy, we all know very well, is going to inhibit the GnRH. So the inhibition of GnRH is what is very important because it makes sure that the LH and FSH does not rise in pregnancy. Now after delivery, the prolactin increases every time the baby is suckling on the breast. So this MCQ has come in the INI-CET, it came in JIPMER once, it came in PGI once, now it's of course INI-CET. Then again it came in the PG entrance in as recent as last year, that what is the prolactin level after a woman has delivered. We would all jump and say that it is very high. Actually, it's normal or it is less than normal. Okay. This part of the question is over. Okay. What is the question? Why is the woman not having periods? Because it is lactation amenorrhea, and we know prolactin suppresses the GnRH. That part is over. Now, I'm trying to tell you something else. There was a question, what is the level of prolactin after the woman has delivered and she's breastfeeding? You know what is the basal level of prolactin at that time? It's normal, or actually it's lower than the pregnancy levels of prolactin. So every time the child suckles on the breast, then the prolactin increases. So that's why there's an episodic rise of prolactin, and that episodic rise is important to suppress the GnRH. So that's the principle why we say that lactation amenorrhea is not the best method of contraception. Why we say that? Because it is purely based on the frequency of breastfeeding. If the child is breastfeeding very regularly, if the mother is giving breastfeed to the child regularly, it's like every 2 hours, or at least 2-3 times when she's in the night also, she gets up from her sleep and feeds. That kind of breastfeeding regularly for a long time will have that episodic rise of prolactin and suppress the GnRH. Only then lactation amenorrhea would be effective. No mother can breastfeed continuously like that. She'll want her 6 hours to 10 hours of sleep. So when she's sleeping, maybe she'll breastfeed just once in the night, isn't it? So that's why we say never tell a woman that the lactation amenorrhea is enough contraception. No, that's not. So yes, method of choice for various conditions some of the time, but for the time being, lactation amenorrhea, give progesterone-only pills. All right, so let's move on. So question number, next question rather, a 38-year-old para 3 live 3 woman presents with a severe secondary dysmenorrhea, and on ultrasonography there is a uniform enlargement of uterus up to 10 centimeters. What is the provisional diagnosis? So PID, leiomyoma and endometriosis are the obvious wrong answers. You already know why, because she is a para 3. Because a woman who is multiparous and is having severe secondary dysmenorrhea, in this first line I am thinking of PID and I am thinking of adenomyosis, but the uterus is enlarged to 10 centimeters. So when there is enlarged uterus, PID does not cause uterine enlargement, all right. It may cause some swelling, temporary swelling, but it's not going to blow up the uterus to a double its size. So normal uterus is around 7 centimeters. There was this question around in INI-CET, isn't it? Normal uterus is around 7 centimeters. Now it's around 10 to 12 centimeters. We think of adenomyosis. Why? Because in a fibroid can be huge, but mostly para 3 live 3 is not associated with fibroids, because fibroids will be more associated with infertility. That's not as a rule, okay. Between adenomyosis and leiomyoma, I am a little inclined towards answering adenomyosis, because severe secondary dysmenorrhea, and fibroids also can have secondary dysmenorrhea, but mostly they have spasmodic dysmenorrhea. So with the information given to me in this question, I would say adenomyosis, because multiparous woman having dysmenorrhea, first thing is adenomyosis. And remember, adenomyosis, the ultrasound signs are getting a little more common in your MCQs. I'm sure the radiologist and the faculty has already discussed a lot about that, but I can tell you that the answer for this question is of course A. I'll show you one picture here of the magnetic resonance imaging, and this is the sacrum here. So this is the posterior part and this is the anterior part, this is the sagittal section through the MRI, and you'll see the cavity here. This is the cervix and this is the outline of the vagina. Now see, look at this part of the picture. Now this is a heteroechoic shadow, okay. This is a heteroechoic, you can see bright spots, you can see dull spots, and this is a posterior myometrial large adenomyoma, okay. Adenomyoma is mostly generalized, but yes, it can be localized rarely. Now this is a large adenomyosis, and this is a typical myohypertrophy which you see in adenomyosis. Remember, a uterus is uniformly enlarged and never more than 14 centimeters in an adenomyosis. So if somebody had asked me a question that there is a mass of 20 centimeters, then adenomyosis is ruled out, because adenomyosis is never more than 14 centimeters. That's as a rule, and it has come in your exams many times. Okay, now let's move on and see something else. A male had a vasectomy 1 month ago. Even after the procedure, his wife is now pregnant. What advice should have been given? The gentleman thought that now he's got his vas ligated, and he's pretty sure that now he'll be having no sperms. He's pretty sure that he'll be firing blanks now. But then what happens? That he has intercourse with his wife and she gets pregnant. I think because the doctor was in a hurry, and after the surgery he forgot to tell the patient that you will have sperms. Yes, this is the place we've done the vasectomy, but this whole area, the vas is not so small, obviously. It is going into the pelvis and then curving around and coming into the prostate, and then prostatic urethra forms. So that vas, when it is going in into the pelvis and then curving, it's a long distance, and that vas will be having the distal to the block, the vas beyond this part of the vas will be having the sperms, and that will take almost 20 ejaculates to finish, up to 20 ejaculates. So a safe bet is tell them that 3 months or 20 ejaculates. 3 months or 20 ejaculates will tell the person to wear a condom, okay. You can also tell him to have abstinence for 3 months, but I think out of the two I would go with the condoms, because it's very difficult to ask a man to abstain for 3 months. All right, let's move on. A Grado 2 Para 1 Live 1 lady underwent LSAS in previous pregnancy for fetal distress. This time she had an uneventful vaginal birth after cesarean section. That is, vaginal birth after cesarean is known as VBAC. Some people would also write TOLAC, trial of labor after cesarean, TOLAC. All right. Sometimes these phrases keep coming in the exams, and I saw one particular exam where they wrote TOLAC, and it was very unfair on the students. So VBAC or TOLAC both can be used. Now she underwent This time she had an uneventful vaginal birth after the previous cesarean. However, the placenta could not be delivered. We say retained placenta after 30 minutes. She was shifted to the operation theatre for a manual removal. Only some parts of the placenta could be extricated. You know, we are going into the uterus, we are using a hand, patient is under anesthesia, we go inside and we have all the freedom to, you know, try and use our hand to the ulnar border to, you know, pull out the placenta. We did all of that. But only some parts of the placenta could be extricated, and now the patient has started to bleed more profusely. So yes, I'm sure you're getting to understand that this uterus had this placenta invading into it, or maybe very badly stuck to it like this. So if there's a placenta which is normal like this and has a fibrinoid layer, see this? This is the Nita Bush layer, Nita book layer. If this is there, and when the umbilical cord is outside like this, we do a gentle, you know, control cord traction, like we say, you know, pull on the cord and give a counter traction on the placenta. The placenta comes out and it separates at the Nita buck layer. Now what has happened? This layer is absent, so the placenta is morbidly adhered. So all of you know that is placenta accreta. It can be placenta increta also in this situation. But yes, succincturiate lobe can cause, but you can pull out the succincturiate lobe easily if you put your hand inside in anesthesia. Inversion of uterus does not suggest in this information, and placenta previa, she would have not delivered normally in the first place. So it's a very obvious and a good question, because when we try to remove this placenta here, you know, we are trying to do a manual removal of the placenta here. We do a lot of hard work to pull this placenta out, but only the bits and pieces come out, and now you tear the placenta and she starts bleeding more profusely. Next thing, what do you have to do? You have to do a laparotomy and try to do the best of your suturing techniques. You know, you'll have to go through and through and suture this, or you may do a lot of figure of 8 suturing here. Maybe you'll be able to save the uterus. So in the quest to save the uterus, don't lose the woman. So if she's bleeding too much, she's getting into DIC, you may have to do a hysterectomy also sometimes. So placenta accreta is one of those whirlpools, one of those pits which I don't want to fall. When I see a placenta accreta, we can diagnose this before a woman goes into labor. We can diagnose this before she is getting a cesarean for whatever reason. If we do a ultrasonography using a color Doppler, we can use a color Doppler and we can diagnose this. So when we can diagnose this on an ultrasonography, we are ready for the uneventualities which may come to us. Now what is the MCQ which has been coming to you regularly? Which condition is most commonly associated with placenta accreta? It is not previous cesarean. See, the question is on previous cesarean, I know that, but placenta previa is more commonly associated with placenta previa, and that's the suggestion given by Williams Obstetrics. So if you see that book, you will understand. You know, unfortunately these good books don't go and write, you know, most common, first to come, last to disappear. That does not happen with both of these good books. So we must read them and make our opinions. So placenta accreta is associated with placenta previa mostly. Yes, previous LACS and many repeated curetages, they also association. Right. A lady during labor presented with persistent occipito-posterior position. Manual rotation was tried, but it was unsuccessful. What is this pelvis type? Now, this is that question which has come in your exams recently, and that was in the MCI exam, but I thought the students who've been reading for the postgraduate entrance should also gain with this. So if there's a persistent occipito-posterior, I'll try and make you understand here. So the most common pelvis obviously is the gynecoid. This is the most common, and the next most common is the anthropoid, and the least common, the rarest pelvis is the platyploid. Now in the anthropoid, okay, I'll use another color. Okay, in the anthropoid you can see a occiput which is here posterior. See, this is the sacrum, isn't it? This is the sacrum here, so this is posterior. In the android also you can see occipito-posterior. Now occipito-posterior, excuse me, it's all gone. So once more, in these two you will see occipito-posterior. Now occipito-posterior here, occipito-posterior here. In the anthropoid, if it tries to rotate, or if you try to rotate, this rotation is not possible because there is side walls. There are the side walls which are narrow. In android, the four walls are narrow like this. So what is the labor rotation in occipito-posterior? In occipito-posterior, if it's in a gynecoid pelvis, it can rotate to occipito-anterior easily. If it is an anthropoid pelvis, it cannot rotate because the side walls are narrow. I hope you can see that cross. Yes, you can see that cross. So it cannot rotate because the side walls are narrow in anthropoid, and in android, it can actually rotate up till here, and the remaining rotation you can do. What you can do? You can put a hand inside this vagina, hold the head of the baby, do a manual rotation and do a forceps extraction. So yes, in occipito-posterior you will see a persistent occipito-posterior, and that delivers by phase 2 pubis. These are the MCQs which keep coming in occipito-posterior. And if it is an android pelvis, it can rotate from occipito-posterior to occipito-transverse, and then you can do a manual rotation and a forceps extraction. All right. Excuse me. So where rotation is not possible altogether, the one which is not possible at all, it is the anthropoid. So that's the answer for your MCQ. All right, just let me go back and see if you guys have been answering to the point, and you've been asking me some questions. Just let me have a look. Excuse me. Okay, you've been giving me the answers and not many questions coming through. What is succincturiate lobe? I'm coming to that, Dr. Banerjee. We are just coming to that. Yes, succincturiate lobe. We are coming to that, Dr. Banerjee. We are just coming to that. Okay. There's another question with all those options. Excuse me. A patient was using IUCDs as a method of contraception. After 2 months of usage, she presents with repeated blackouts, syncopal attacks to the emergency room. What is the likely cause? It's not that she's coming repeatedly to the casualty like morning and then after 3 days for blackouts. It's that she's having blackouts regularly and she's come to the casualty. Now that whenever I get up, I fade out, I pass out. So IUCD as a method of contraception, and now she's having blackouts. So yes, IUCDs can cause ectopics. Now please hold your guns. I said IUCDs can cause ectopics. I will want your consideration here a little bit. Please stop looking here and there. Please listen to me properly. IUCDs actually reduce the number of pregnancies. That's why they reduce the number of ectopic pregnancies. Please remember this line. Don't say IUCDs cause ectopic pregnancies. Don't say that, please. If IUCDs were causing ectopics, why would I give IUCDs to anybody? If I say that I'm putting this IUCD and you'll have a baby in the tube, nobody's going to take an IUCD. Please don't take this message. IUCDs will reduce pregnancies, don't they? The failure is 0.5 to 0.6% only. So a woman who is, suppose 100,000 women are taking it, so less than 500 women are going to get pregnant. So please remember, IUCDs will reduce pregnancies, they'll reduce ectopics, okay? So now, if a woman is pregnant, let's say a normal woman is pregnant, and a woman is pregnant with an IUCD inside of her, like this. So this is a normal woman, this is a woman with an IUCD, and if this woman gets pregnant, the first one gets pregnant, we know the pregnancy will be 99% inside the uterus and 1 to 2% it might be in the ectopic gestation. However, if a woman is using IUCDs and she conceives, where will be the baby? Where would you find the pregnancy? You must please remember that 95% of times it is inside the uterus still. Only around 5 to 6% time it might be an ectopic. So please, if a woman conceives an IUCD, rule out an ectopic. That's the line which you have to understand. Woman is taking IUCD, pregnancies are less. If a woman is taking IUCD, ectopics are even lesser. If at all she conceives, relative chance of having an ectopic increases. So yes, I've given this woman an IUCD. If at all she conceives, come fast. I'll do an ultrasound and rule out an ectopic, although I know that 95-96% time is going to be in the uterus. Same logic is also used for the progesterone only pills. All right, please understand these things very clearly. Okay, so yes, IUCD with a pregnancy, what do you do? When a woman is pregnant with an IUCD, first thing, remove the IUCD, tell her continue the pregnancy. And if you continue the pregnancy, you may still abort for 25% of times, but yes, with an IUCD, it's up to more than 50%. So if you have an IUCD and you're pregnant, I tell the woman, you have to take out the IUCD first. I speak with her that, do you want to continue the pregnancy? I want the child, it's okay, I was taking a contraceptive but it failed. So, sir, can you advise me, can I continue the pregnancy? Yes, you can continue the pregnancy, come to the antenatal clinic, but you have a chance of aborting up to 25% even after removal, okay? So yes, the likely cause here is a ectopic pregnancy. This you knew well, but then I thought I must discuss the options with you properly. Okay, next question. A pregnant female delivered a baby with normal expulsion of an intact placenta. After 48 hours, she started bleeding per vaginally. On examination, she was hypotensive and a boggy mass is palpated per abdomen. Uterus showed tissues in the cavity. What is the likely diagnosis? Okay, she's delivered, now she's bleeding after 48 hours. So this is secondary PPH, yes. After 24 hours to 12 weeks is the secondary PPH, okay. Earlier they said 6 weeks. Now for the last 7-8 years we know there are secondary PPHs after 24 hours up to 12 weeks. Now what is the likely diagnosis in this one? Succincturiate placenta. Succincturiate placenta is that the cord is attached here and there is a leash of vessel going like this to another small placenta. It is part of these vessels only, okay, like this. So there is a small placenta which is like an accessory lobe. So succincturiate placenta is also known as the accessory lobe. All right, Dr. Banerjee? Right. Now, is it a succincturiate lobe? It can be. It is presenting as a cotyledon which has stayed back inside. Is it adenomyosis? Not likely. Adenomyosis which has delivered is not going to show a boggy uterus. It's not going to be the presentation. Yes, adenomyosis may bleed a little bit more during the time of delivery. Not the answer here. Placenta accreta? Yes, it can be. It can be placenta accreta, but the ultrasound showed tissues in the cavity. Okay, so more or less ruled out. It is very typical that secondary PPH is the question. So I'm going to think of retained bits of tissues first. All of you know secondary PPH is retained products of conception. That's the term we use, RPOC, retained products of conception or retained bits of tissue we say. So yes, that is the secondary PPH most common cause. So placenta accreta not likely. Fibroid uterus can cause PPH, can cause secondary PPH, but what is most likely? It's a good smart question and good choices have been given here. I would still go with a succincturiate placenta, a accessory lobe. Now that's the answer to this question. Now what should you do in any delivery? Moment the baby is born, then what we do? We wait for around 2-3 minutes and we see if the placenta is coming out by itself. Mostly what we do a controlled cord traction. We are pulling on the cord and giving a counter traction on the fundus of the uterus. So that is what is controlled cord traction. So when I do this controlled cord traction, the placenta mostly comes out. And how do I say that the placenta is complete? You know, I don't hold the placenta like this. I place it on the back of my hand. So I take the placenta, place it on the back of my hand like this. So now my hand is making a inner cavity of the uterus, like the dome of the uterus. I'll show you that. If the uterus had a placenta attached like this, so I keep the placenta on my hand this way. So this is like the dome of the uterus. I keep the placenta on the back of my hand and I inspect the placenta. And see, that's what I'm doing in this picture. I've put the placenta on the back of my hand and you can see now that I examine for the cotyledons here. Now when I see this placenta completely, all the cotyledons are there are no gaps, then I know the delivery is complete. So if the placenta is deficient, like in this picture, okay, see there is a deficiency here. I deliberately took out a cotyledon just to show. So this placenta with a deficient cotyledon here should give you a doubt that is something retained inside. So, retained placenta is, this is the picture which comes. Now, the question, the choice in this one, the answer is succincturiate lobe. What is succincturiate lobe? You will see that the placenta is fairly complete, like this one, the placenta is fairly complete, but you will see a small leash of vessel going like this, and there is nothing else. Of course, this part is inside the uterus in the succincturiate lobe. So, look out for these small vessels which are on the periphery of the placenta. If you see those and there is a deficiency in the membrane at that area, you may be also missing a succincturiate or an accessory lobe. So, what did I say? If there is a placenta, examine it. There may be retained cotyledons inside in any normal placenta. If there is a placenta with deficient membranes on the periphery, deficiency in the membrane, the whole membrane is seen, but one part there is a deficiency, maybe there is a succincturiate lobe inside. So, both of these retained bits of placenta or a succincturiate lobe can cause secondary PPH. Answer to this question obviously is the placenta succincturiata. All right. So, let us go to the next one. Antenatal ultrasound at 22 weeks in a primary gravida suggests an anterior grade 1 placenta with vessels of the cord ending a few millimeters away from the placental margin. The type of presentation is associated with an increased risk for which one? Maternal hemorrhage? See, let me just show you that there is a placenta, vessels of the cord ending a few millimeters away from the placental margin. The ending like this. So, this is what I already told you. This is the velamentous cord, and a velamentous cord, all of you know that it can break, you know, there can be a fetus here, they can, sometimes it is in the lower segment, sometimes this arrangement is like this, in the lower segment there is a baby here, and when he delivers, yes, you may see the placenta is not low, placenta is not in the lower segment, it is the baby, when the baby is going through this placenta, this vessel. So, this is a velamentous cord at the internal os. So, velamentous cord at the internal os, what do we call it? We call it a vasa previa. A vasa previa is a complication of all velamentous cords do not become vasa previa. Please remember that velamentous cord placenta can be in the upper segment also, but if it is in the lower segment over the internal os, a baby can go through it and break his own umbilical cord, break his own blood vessels. So, yes, maternal hemorrhage, no, it is fetal hemorrhage, can cause fetal exsanguination before labor due to blood loss, correct. Exsanguinated, totally bereft of blood, the blood has gone away and he is exsanguinated. So, yes, that is the answer. Torsion of the umbilical cord, increased fetal malformation incidence, distracting choices, but the answer is B for Bombay. All right. Third stage of labor is defined as the period between delivery of the baby till the delivery of the placenta. All are true about delivery of the placenta in the third stage of labor except. So, something about the placental delivery has been asked, and which of these four statements is wrong regarding the placental delivery? Separation of the placenta always manifests as reveal bleeding PV and is the most specific sign. Now, this is wrong, isn't it? Bleeding from the uterus can be so many causes. Okay? It can be a placenta which is perfectly attached and there is nothing wrong, but it is still bleeding because after the delivery of the baby, the placental edges, they bleed a little bit. Yes, when the placenta separates, there is a gush of blood, agreed, but just the gush of blood from the uterus is not enough diagnosis, it can be so many other causes. So, yes, lengthening of the cord becomes longer, placenta separation, maybe, but the cord can snap and become longer. So, that is why it is also not specific. So, the most specific sign is actually that when this placenta separates, if you can imagine here a little bit, that when this placenta separates from here and it is coming down into the uterus a little bit, then these uterine muscles here will contract. So, when they contract, you can feel it from the tummy on the mummy, right. You can put your hand on the abdomen of the mother and you can see that there is a hard globular mass. So, suprapubic bulge or a suprapubic hard globular mass, most definitive sign of the placenta having separated. So, this is a wrong choice. Lengthening of the cord is a sign of placenta separation? Yes, maybe. Fundus of the uterus may be palpated after placental delivery to rule out atonicity. We should palpate all the uterus and see if the uterus is having good tone after every delivery to rule out PPH happening, correct. Placenta accreta may be a cause for retained placenta. Yes, that's what we discussed just now. So that's the answer to this question, that A is not a correct statement. Okay. A woman at 29 years of age, prima grada, presents to the antenatal clinic for routine evaluation. Her glycosylated hemoglobin HbA1c done in the first trimester was normal, and she does not have any history of diabetes. Okay, let me just try and explain what is happening here. We should screen in the first trimester for diabetes, and we should screen in the second trimester for diabetes. First trimester, we look for the pre-existing diabetes. If she is a diabetic before and she does not know, I look for the glycosylated hemoglobin. It should always be less than 6.5. Better less than 5.8, but less than 6.5 definitely. So that is first trimester screening of diabetes, pre-existing or the over diabetes. After 24 weeks, she can have gestational diabetes. Then I screen her again for gestational diabetes, and that is by the GTT using 75 grams, one step. Okay. That is the American Diabetic Association recommendation. So we screen first trimester by the HbA1c, and the second trimester after 24 weeks we do the GTT with the 75 grams of glucose load. Okay, yes, you know the fasting levels should be less than 90 and 1 hour should be less than 92. I'm so sorry. Once again, fasting should be less than 92, 1 hour should be less than 180, and 2 hours should be less than 153. So this is the screening in the second trimester, and we call it the one-step staging, one-step screening. Now, her glycosylated hemoglobin done in the first trimester was normal, and she does not seem to have any history of diabetes. Her glucose tolerance test now done at 24 weeks show a 2-hour value of 180. 1 hour value should be less than 180, 2 hours should be less than 153. So if it is any one abnormal value in the GTT, any one abnormal value is diagnosis of GDM. One step. This is not that you do a screening test first, then you do a diagnostic test. What was done earlier? I think those who are final year MBBS students, yes, you may still have been taught in your classes that we do the glucose challenge test with the 50 grams, and then we do the glucose tolerance test with 100 grams. Yes, it is not wrong teaching, it is correct. But we use this system now. This is the American Diabetic Association recommendation, and this is what is used across the country in most parts of the world. And this is what is coming in exams more importantly. The AIMS people have been always asking this for the last 2 years. So remember the one-step GTT. So this is what is used, and this 2-hour value shows 180. That means she is a diabetic. Which of the following complications is not expected in such a case? Now diabetes can have abortion, have preeclampsia. How much is the incidence? How much is the association of diabetes with hypertension? 25% of diabetics may have hypertension also. MCQ. Infections, yes. Oligohydramnios. Now, one thing which you should remember, that diabetes is equal to polyhydramnios. Okay, oligohydramnios is not a feature. Look, recently I've been some live classes have started in few places in the country, and I was speaking to some students, and I asked somebody that what are the problems of diabetes and what can happen to the mother, what can happen to the baby, and somebody said diabetes can cause IUGR. Look, please don't say that. Burnt out diabetes, end stage diabetes, microangiopathy and end arterial disease. I mean the full gamut of diabetes has happened, and the woman is very sick with diabetes, and if she's pregnant, she'll have an IUGR. But diabetes is equal to macrosomia, large baby, big baby, whichever way you want to say it. Please do not do these mistakes. Somewhere, there's a list of things which can happen to the mother and the baby. There's like diabetes, these problems, and these problems, and these problems, and these problems. And the last line somewhere is IUGR. And I don't know why you remember that last thing. So please, IUGR is not related with diabetes for you people. Please remember, diabetes is equal to large baby, it is equal to polyhydramnios, and it is not equal to oligohydramnios. Okay, let's move on. For performing the procedure depicted in the picture, the reproductive medicine specialist has to choose a sperm which will be the best. I'm sure you can make out this procedure. There's a oocyte which is held by a holding pipette with negative suction, and there's a oocyte with the polar body here. There's a metaphase 2, M2 oocyte which we use for insemination, and there's a needle here. Can you see this needle here? All right, yes, there's a needle here. This is already having a sperm loaded here. You can't see that in this picture. It's a little behind. This is picture taken in my lab. It's a little behind in that injecting needle. So this needle is now injected is injected into this oocyte, and then the sperm is directly left into the cytoplasm. So, yes, all of you know that this is the intracytoplasmic sperm injection. So, this procedure, of course, they are just trying to ask you the same question in a different manner, that for this procedure, that is intracytoplasmic sperm injection, which are the following semen characters will help the doctor decide the best sperm? In effect, which of the semen parameters is the single best parameter? Now, that line is not been asked, they ask you the same question in a roundabout way. So, if I am going to do ICSI and I am going to do it for the person with the best chosen sperm, you know, whatever the indication of ICSI, we are not going to that. Yes, when they are very low counts and very occasional motile sperms, or I have aspirated sperms from the testes and I am using those sperms. So, if I am having very few sperms from the male, then I can't do IVF, yes. For in vitro fertilization, you know, in vitro fertilization, there is a oocyte in the test tube, and in this oocyte, I will put a whole lot of sperms. How many sperms? At least 1 lakh sperms per oocyte. So, for a good IVF for let us say 10-15 eggs in the lab, you must have IVF for an IVF around 5 million sperms. 3 to 5 million sperms should be the count at least. Now, if he has got very few sperms, he has got you know, occasional motile sperms in his sperm count, or we have to take out sperms from the testicular aspiration procedures, then those few sperms, how do I choose? How do I choose that they are the best sperms for making the oocyte fertilized? So, motility should be good, or the count should be good. Count is anyway less. So, count is of no significance in this situation for this method, because we need 1 sperm. So, good motile sperm, or a live sperm, or a good morphology and live sperm. So, yes, it is very clear that if the motility is good, but the sperm is having globospermia, or it has got a bent neck or a broken neck, it will never fertilize the embryo. It will never fertilize the oocyte and make an embryo. In fact, even if it fertilizes, the embryo won't grow. So, what do you have to do? You have to get the best sperm and morphologically normal sperm. So, that is why I keep telling you morphology is the single best parameter. Why? Because a morphologically normal sperm and a live morphologically normal sperm, we can use just 1 sperm. If he has got absolute azoospermia, take out tissues from his testes and pull out 1 sperm out of his testicular tissue, and that 1 sperm can fertilize the oocyte if it is morphologically normal. So, that is the criteria. So, that is why now whenever you have been hearing this answer of motility being the single best parameter, I know now most books and everywhere else you have been told now that it is morphology. Please let us not debate about this anymore. That is the single best criteria. Okay? So, good morphology, and I will use it for ICSI. Okay? Right, getting into obstetric questions. I got a mix of questions, you know, gynae and obstetrics, and then reproductive medicine, and then endocrinology, and you know, cancers. So, I will just see if something else was coming. Yeah, just a minute please. Mostly people giving the answers. Succincturiate causes retained bits. Yeah, Dr. Patel, yes, succincturiate by itself is a small lobe, and that is what is retained. So, yes, placenta, any placenta can cause retained bits, some part of it like I showed in the picture. And succincturiate lobe, if it stays back, it behaves like a retained bit. Okay. Okay, a lot of discussion going amongst yourself, exclusive fetal blood loss. Yeah, I can see that they are mostly oligodrones, abortion, yes. Big baby always. Right, mostly answers. Okay, so I'll move on now. Multiparous woman after delivery, the placenta starts to bleed heavily. On examination, the cervix, the cervix and the vaginal walls are healthy, but the uterus is large and flabby. All of the following can be used for the management. PPH again. Please remember, PPH is that one topic you cannot leave your home without reading. Please always PPH, antepartum surveillance, intrapartum surveillance, preterm labor, some exciting topics about obstetrics which you should know. Now, all of the following can be used for the management except you can use Mesoprostol, we always do, and my favorite route is rectally, 800 micrograms to 1000 micrograms I use. Oxytocin, you know, is the drug of choice, no doubt about that, and prostaglandins like, prostaglandin F2 alpha is my favorite in prostaglandins, that is carboprost. But mifepristone is not used, come on, that was an easy one, because mifepristone is an antiprogestin, so not to be used for PPH, it's got no proven use. But yes, what is now being asked, and it may become a choice for you people, this question, easy question, was kept only for the purpose of introducing this one, tranexamic acid. Any bleeding anywhere, now think of tranexamic acid, and it is used for PPH now. Okay, so please see that if a choice is tranexamic acid, don't say that it is not used. Tranexamic acid across the world now, there are many journals which have come, they say that go ahead and use tranexamic acid. It is good adjuvant along with the oxytocin or the methyl ergometrin you're giving. Now, carboprost, how many you can give in 24 hours? That was a question. Up to 8 in one day. Up to 8. Methyl ergometrin, if they ask you, methergin for trade name which we call it, methergin can be up to 5 per day. Okay. So, carboprost 8, methergin 5. Now, a third gravida, a gravida 3, 2 abortion patient who's previously had 2 midterm abortions. You know what do you mean by midterm? There are 3 terms, the second trimester. Has a cervix of 15 millimeters length, short, per vaginal examination at 14 weeks of this pregnancy. So, normal cervix is 3.5 to 4 centimeters and this is 1.5. All of you know already that what we're talking, it is less than 2.5 centimeters is a short cervix. Okay. Her blood and hormonal workup is normal. She was immunized with MMR vaccine in her childhood. What could be the cause of the previous 2 abortions? Now, this is straightforward, incompetent os or a short cervix. Yes. Now, why did I give you this question? Because some of you are now getting a little misled about the causes of abortion. And I've been asked this question so many times on the forum that I feel I must discuss here, that first trimester abortion are chromosomal and the second trimester abortions are anatomical, okay, and second trimester can be antiphospholipid antibody syndrome, but it is not the most common, okay. The most common causes, most commonly, first trimester is chromosomal, second trimester is anatomical. Yes, antiphospholipid antibody syndrome can cause second trimester abortions, it can also cause first trimester abortions, it can cause intrauterine deaths, that is after 28 weeks if a baby dies. So, antiphospholipid antibody is not trimester specific. It can kill a baby in the first, second trimester or in the third trimester. And if it is killing a baby in the second trimester, it is still not the commonest cause. I have repeated myself 3 times. So, you know what I am going to say about that, right? So, don't change your answer just for the sake of following some place where you heard about it. Please remember, it is extremely important that antiphospholipid antibody syndrome is well understood. It is a disorder of thrombophilia, affiliation to make thrombus, thrombophilia, tendency to make thrombus. So, thrombophilia, read about it a little bit. Thrombophilias can be acquired or inherited. Acquired ones are the protein C deficiency, protein S deficiency, and the inherited ones are the antiphospholipid antibody syndrome. Must read about it and the criteria also, okay. It is a nice long discussion, but remember the inherited ones, the protein C, protein S, factor V Ladin, methyl tetrahydrofolate reductase deficiency, homocysteine deficiency, all of these please remember, okay. Chalo. Please find time to read this, especially PG entrance people, you must find time to read the basis about that. Basically, thrombophilia means tendency to make a thrombus. If there is a thrombus, it will block the blood flow in the small placental vessels and there will be a problem of abortions. If there is a antiphospholipid antibody or a thrombophilia happening around, let us say 32 weeks, presenting at that time. So, the blood vessels are fairly big, but they will get narrow because of the thrombus. So, what will happen? Mother will increase her stroke volume and increase her blood pressure to overcome that block. So, PIH can happen, okay. So, in a gist I told you, I did not write about that, but I hope you will all find time to read about the thrombophilia in your exam preparation. So, this is incompetent os. Now, first sign of magnesium sulfate toxicity. Now, if you're reading medical disorders in pregnancy, you're obviously reading PIH, that is hypertension in pregnancy, and GDM. And when you read eclampsia management, magnesium sulfate, please read the pharmacology well, and pharmacology of calcium gluconate and magnesium sulfate. Why? Because the antidote of magnesium sulfate toxicity is calcium gluconate. Magnesium sulfate, the mode of action and its neuroprotective role in preterm labor stoppage and for the newborn child. All these things are extremely important aspects of magnesium sulfate. Only neuroprotective drug when given as a tocolytic. Magnesium sulfate is given for convulsion, what we are talking now. It is also given as a tocolytic, and it is the only neuroprotective. You know what is the meaning of neuroprotection? Neuroprotection. You know, it's given in most of your journals and wherever you read about preterm labor. Neuroprotection means lesser cerebral palsy for the preterm baby. All right. So magnesium sulfate toxicity, how does it show? So the required amount of magnesium sulfate is around 4 to 7 milliequivalents per liter. That's the therapeutic level, and it's a central cerebral suppressant that reduces the convulsions. So if the convulsions are reduced and you are continuing the 4-hourly 5 grams magnesium sulfate, the maintenance dose for 24 hours, you are always looking for 3 things at least. Apart from BP and pulse rate, you are looking for knee jerks, respiratory rate, output. Now, the first sign is knee jerk suppression. Now, those are the levels which you should remember. Loss of deep tendon reflexes. 4 to 7 is therapeutic level, 8 to 10 loss of patellar reflexes, okay, the knee jerk, and 10 to 12, 10 to 15 they say respiratory depression, and 12 to 15, you know, more than that, you know, I should have written more than 15, okay, around 15 and more, there will be respiratory paralysis, and 25 to 30 there will be a cardiac arrest, and I have mentioned here that the treatment is by calcium gluconate, all right. 10%, 10 ml of calcium gluconate. Now, a primary gravida at full term pregnancy with no high risk factors in the 3rd stage of labor. All of the following steps are mandatory except. Oh, now that's the question which I kept a little bit later because if I had started this early, a whole lot of controversies would have come in the chat. Now, you know what I'm going to answer, right? That all of the following steps are mandatory in a case of 3rd stage of management, that is 3rd stage, active management of 3rd stage of labor. Cord clamping is the least important of the methods which you employ. You know, early cord clamping or the delayed cord clamping, it is given straight away in all your major books that it is of no consequence. It is the least important, okay. In fact, they actually taught you early cord clamping. So many places you've been taught about this, so many books wrote early cord clamping. Now, the pediatricians got really angry. They said, why do you want to clamp the cord so fast? Keep the baby, let the blood go into the baby for some time, at least 1 minute you should wait. Some people say wait up to 3 minutes. So, at least 1 minute you should wait, let the blood from the placenta go into the baby after delivery a little bit more. His hemoglobin will increase. So, you should actually do a late cord clamping or a delayed cord clamping. So, earlier you people used to argue with me, so you keep saying delayed, actually most books says early. Now everybody is saying delayed cord clamping. So correct, delayed cord clamping is the method which is applied in active management of 3rd stage of labor, and it is not early cord clamping. So the answer is this, end of discussion. Other 3 are correct, including uterine massage. I know you people must be already answering that don't do uterine massage. Please do uterine massage, guys. All of you who've been working in government hospitals and you've been working in the institutes and you've been working in state medical colleges, please remember when you were interns, what did you do when a woman delivered? Moment the placenta came out, you pulled the placenta out and you put your hand back inside the vagina and one hand on top of the abdomen of the mother and gently give a gentle massage. That uterine massage will contract the uterus. Please, we always do that for any woman who delivers. There's a lot of controversy. I know you will keep quoting WHO. We all love WHO. WHO is for countries like us, but it is also for countries like Africa where there are things which are much worse than us. So remember what, now I cannot tell you the names and I can tell you the people whom I have discussed this with, but yes, people at our level who are extremely senior, we don't follow in our country everything what WHO says, okay. WHO actually says that active management of 3rd stage of labor is 5 centimeters. We are still at 4 in our partogram, isn't it? In fact, the Americans say it is 6 centimeters. We are still at 4 centimeters, aren't we? So yes, we are not disregarding WHO, but remember, uterine massage is done. Now, what is not done? Rigorous, fervent and rigorous uterine squeezing, that should not be done. It is going to cause pain. So sustained uterine massage, that should not be done. You do a gentle massage, it reduces the bleeding. So uterine massage, delayed cord clamping, of course, control contraction with oxytocin. So why not 4 steps? Why do you say always 3 steps? We can have 4 steps, okay? So yes, control contraction, oxytocin infusion, which is the drug of choice, uterine massage, and a late cord clamping, okay? So active management third stage of labor, administration of uterotonics, oxytocin, control contraction when stillbirth attendants are available, and late cord clamping 1 to 2 minutes, massage of uterus after the placenta delivers, okay? Now, I just got you some references. This is from Williams Obstetrics, and it is very categoric here that active management third stage of labor, they still say early cord clamping, but you must remember late that early cord clamping, it was given that early cord clamping and delayed cord clamping does not increase postpartum hemorrhage. So early cord clamping is less important component of this trio. Please remember, early or delayed is of less importance. And cord traction also may be less critical. Uterine massage following placenta delivery is recommended by many, but not all. I agree, just like we had a discussion. Countries like ours, please do uterine massage. To prevent postpartum hemorrhage, we support this with caveat that evidence for this practice is not very strong. See, we support, William supports, the books which we read, it supports. So please don't say it is contraindicated, it hurts me. That's why I'm trying to tell you this so fervently and so strongly that please do uterine massage. They support, the Americans support it, and we Indians, we should understand that PPH is a major problem. 8 to 10% of women who deliver have postpartum hemorrhage in our country. What is the most common cause of maternal mortality in our country? Obstetric hemorrhage. What is the most common obstetric hemorrhage? PPH. And please do uterine massage. Now, I hope this is recorded and this is played by some of you. If you have not read, please tell your friends. Go through this discussion. And remember, uterine massage is the part. Fine, fine. Okay, I'll move on. You guys must be saying okay, but one more slide I got for you from WHO. Now, remember, WHO says that it is contraindicated. So, see, control cord traction was revisited because of new evidence. The intervention is now regarded as optional in settings where skilled birth attendants are available. So, this itself is having a contraindication, having a discussion now. There might be some argument even in the control cord traction by WHO itself. So, what was taught to you by WHO, what you keep quoting, they themselves have some reservation about even control cord traction. Now, uterine massage is not recommended as intervention to prevent PPH in women who have received prophylactic oxytocin. It may cause maternal discomfort and require dedicated health professional. Now, that is where I have highlighted this for you. A dedicated healthcare professional is required. So, in Africa, there are not many people, I'm so sorry. I would love Africa to become even at least as good as India, but most of the countries in Africa, they don't have many doctors in the peripheries. So, excuse me, there's a doctor, there's a nurse, and there's a driver, and 3 people are running a small hospital, and there are 15 women delivering, and 3 are having PPH, and 2 are getting a cesarean done. 1 patient is postnatal, is going to shock, and there's a whole lot of commotion going on in obstetric wards there because there are less people. And those places, skilled workers are very less, and in villages, even these are not available. So that's why to give a control cord traction and to do a uterine massage, there are not many people. In fact, WHO also says self-assessment of the uterine tone. Tell the mother to feel her uterus. And if it is tight, it's fine. If it is loose, call me. I mean, she's in a ward, is lying down, there's no doctor able to see because he's busy. Those areas, it's recommendations for such countries where skilled workers are not present. So, when we are talking about the active management of third stage of labor, we are talking about countries like ours where skilled laborers are present, skilled labor is present. Doctors are much more than Africa here in India. So, please do uterine massage, okay. So, and this one, the last one is a little funny, surveillance of uterine tone through abdominal palpation is recommended in all women for countries where they don't have skilled workers. Some people were telling me, sir, nowadays self-assessment of uterine tone is what is done. I mean, you tell the woman that put your hand on the tummy and if it gets loose, you call me. Now, what are you going to do in the labor room if you're not going to see for PPH? Now, I'm going to go and sleep, and there are 2 deliveries now happening, and both are just feeling the uterus, and you're sleeping in the labor room. That's nonsense, isn't it? So, uterine assessment of the tone, please don't follow blindly what is written in WHO, okay? It's an extremely good organization, and it's a very important organization for all of us. We follow WHO for most of the things, but not everything is followed to the T, okay? So, I'll stop here. This topic is a little touchy for me, and I hope you get the message of uterine massage. Okay, a 19-year-old girl with primary amenorrhea with normal secondary sexual characteristics. On examination, the vagina was shallow and blind, and a per rectal examination, no uterus was felt. You know, a 19-year-old girl with primary amenorrhea with normal secondary sexual characteristics. So, yes, primary amenorrhea, the girl is not having periods, but she's having secondary sexual characters. So, she's normal as far as things are concerned in her endocrinology, but her anatomy should be a problem. So, yes, we are already thinking in terms of Mullerian anomalies like complete Mullerian genesis and testicular feminization syndrome, but there is secondary sexual characters like pubic hair. So, testicular feminization, no working androgens, no secondary sexual characters. So, that's why rules out testicular feminization already. Now, there was no uterus. Which is the investigation which can best inform the diagnosis here? Ultrasound, yes, both testicular feminization and a Mullerian genesis, both will not have a uterus. If you're smart enough, then you can look at those small thin testes somewhere in the inguinal canal, but that can be missed sometimes. So, you may see and you may want to confirm more. So, ultrasound alone is not enough. LH and FSH will be the same. It's a normal man and a normal woman. So, LH and FSH will be baseline. They will not be too high or too low. So, testicular feminization and Mullerian genesis, LH, FSH are mostly normal. Estradiol estimation. Estradiol is high in a woman. Estradiol is higher in a person who is testicular feminization because his androgens are converted into estrogens. So, yes, the best thing to use and confirm the diagnosis is a karyotyping here. All right. So, that's the answer. A 52-year-old lady came with 18 months of amenorrhea, 52 years, that is 51 is the world average of menopause, 47 to 48 in our country, and 1.5 years no periods. The test results that you would expect are, that is, in a woman who is menopausal, what are the test results? High LH and a high FSH, isn't it? I think I don't want to look the other choices. High LH and high FSH in a menopausal woman, that is straightforward. So, yes, normal FSH is 2 to 6 international units, and more than 15, more than 10 I will say for you people, more than 10 is SO, suggestive of menopause, and more than 40 is diagnostic of menopause. So, yes, a level more than 40, we say that the woman is in menopause, and if it is FSH more than 40 international units, less than 40 years of age, that is, she is menopausal before 40, that is premature ovarian failure. I have written P for premature ovarian failure. Okay, that is the story about the FSH values. Okay, yeah, that's the same thing to explain that this is the normal hypothalamic pituitary ovarian axis, and that's menopause. We've already discussed that. Let's move on. Medical termination pregnancy can be done in all of the following conditions except, okay, indications for an MTP: baby with disability or serious genetic disorders. Yes, that is the indication. Failed contraception, that is the indication which is most commonly misused. Yeah, most women would come to us and get an abortion done just by saying that, okay, we use the condom burst and I'm pregnant, I have to go and do an abortion. I can't say no, because whether she was using a condom or not, that you can never prove. Okay, so this is like a virtual visa. You know, anybody who wants an abortion can say contraceptive failure and get an abortion done. So that's my personal opinion, that I don't like this, but yes, it's an indication. So we have to go with the law of the land, and the law of the land says failed contraception is an indication for abortion. That is doing an MTP. Large family. I have a large family, I don't want this child. Not enough. You should have not got pregnant. So don't say that, say failed contraception. Then probably even if you have 7 children, the doctor is legally bound to do the abortion. So yes, large family is not the indication. Harmful for the mother is. So, yes, MTP indications are continuation is risk to the mother, substantial risk to the fetus is anomalous, fetus is having some congenital defects, chromosomal defects, etc., etc. Pregnancy due to rape, humanitarian cause, we know that, and contraceptive failures. But all of this should be done before 20 weeks. No, things have changed a little bit now. All of you know that the MTP law was amended once again in 2021, very recently. Now, what is the amendment? So, that amendment which came in 2021 in the Gazette of India, and that says when the length of pregnancy does not exceed 20 weeks, we can do abortion. Where the length of pregnancy exceeds 20 weeks but does not exceed 24 weeks, cases of such category of women. Okay. So, now we say 24 weeks and people can have an abortion or an MTP done when the pregnancy is beyond 20 and up to 24 weeks. But yes, if it is after 20 weeks, then 2 gynecologists have to supervise the abortion, and it should be approved by a board. Approved by a board. Okay, you cannot just say that okay, she is having 23 weeks and the patient comes to me, sir, I want an abortion, I'll go ahead and do the abortion. Please, the implementation of this is still a long way. We know the rule has changed, it is 24 weeks now, it has not been implemented yet. We are waiting for more clarity on the issue. That's why this didn't come in the last 2 exams. But remember, if I have to do an abortion at 23 weeks, I must seek permission from the board of the state. Every state has to constitute a board of pediatrician, gynecologists, and a pediatric or a neurological surgeon who will specify that this baby will not make it. So, go ahead and do an abortion. Now, it is legally permitted to go up till 24 weeks. Implementation may still take some time. Okay. So, multigravida who is gravida 4, para 3, live 3 presented to the casualty with pain abdomen and vaginal bleeding. On abdominal examination, the doctor could feel the limbs easily, and on per vaginal examination, he was unable to feel the presenting part properly. Look, the answer is in this part of the question. On abdominal examination, the doctor could feel the limbs easily, and on per vaginal examination, he was unable to feel the presenting part properly. That is, he's done a per vaginal examination, suppose there's a head and you try and go and feel the head, but the head is very high, or even if it's the breech, it is very high. He is not able to know. You know, when you do a per vaginal examination labor, everything is inside the pelvis. Even if it is a CPD, you can feel it, but you're not able to feel things easily. They are very high. So, this is what happens in a ruptured uterus. The uterus is torn, the baby has come out into the abdomen, from the uterus has come out into the abdominal cavity. You can feel the parts easily, and yes, if the head is gone away from the pelvis, you will not be able to feel the presenting part properly. So, that's the story. The cervix was 5 centimeters dilated, but not well applied. Now, that is the other information which has come. The cervix was not well applied. All right. So, if the head is inside the in the pelvis and it is in the cervix, then only the cervix will be well applied. So, loosely hanging cervix, you cannot feel the presenting part, and the parts of the baby are easily felt per abdomen. So, that's a classical ruptured uterus. Okay. Abdominal pregnancy, she will not come in labor first, it will never dilate the cervix. The abdominal pregnancy will never dilate the cervix, this will never happen. Abdominal pregnancy is in the outside the uterus, right, it will never dilate the cervix. Uterine rupture is the answer. Obstetric labor, the presenting part will be easily felt. Of course, it will be eddy matters. Suppose the head, it will be eddy matters, it will be stuck in the pelvis, it will be dry pelvis. Yes, all that is there in obstetric labor, but you will feel the presenting part easily. Obstetric labor, if it is neglected, can rupture a uterus, that is correct, and then the baby's head will go up. Abruptio placenta, you cannot feel the part so easily because the uterus is very tense, and a tense uterus with a retroplacental clot and then the baby behind that, you are not able to feel the feel parts, and when you try to feel, it is very tender also. So, yes, the answer is very clear here that it is a ruptured uterus. Okay, it is a ruptured uterus. Now, this is a question which I wanted to discuss. What is the best treatment of cervical cancer presenting in the stage 2B? Now, stage 2B, what are the the basic guidelines? I have got you the full guidelines, but always remember CA cervix. If any one of you has some old guidebooks, please stop reading CA cervix before 2018. 2018 September, the journals came out, and it was proven by Indian doctors. I should not be taking names here, but then very famous institute and very famous doctors in that institute, and so much of work done in CS cervix in our country, and we Indians publish a lot nowadays. I'm so happy that we're doing this. So our work has been recognized by the world body, and the International Federation of Gynecologists and Obstetricians have decided to amend the CS cervix rules in 2018. And then we said there's a stage of 3C, pelvic and parotid lymph nodes. This was not there before. There was only 3A and 3B. So stage 3C was introduced. Pelvic and parotid lymph nodes should be seen. And how do you see those pelvic and parotid lymph nodes? You cannot do a palpation, you cannot do a PV. You can see only by imaging. So imaging now required for the staging of CS cervix. I know you know this now. Most of you know this, but if some of you didn't know, it's for you guys that imaging now required. Before 2018, we used to say, that is even before 2000, till the end of 2018, in fact, we have taught you that imaging not required for CS cervix staging. But now we have to say that imaging is required for the stage 3C. Then only you can know it is stage 3C or not. So that's about the staging. Now, when this guidelines have come out, we say stage 1 to 2A1, and after 2A2, the best treatment, this is radical hysterectomy, and this is chemoradiation. Now you must know this. Earlier it was, just in case you want to know, it was till 2A and after 2B. Now we say 2A1 and 2A2. This is earlier, right? Okay, so you don't have to remember these ones. So beyond 2A2, we now say you must give chemoradiation. That's the split now. So your question answer is fairly simple. For 2B, you will have to go ahead and give chemotherapy and radiotherapy. So this is brachytherapy given here. Chemoradiation I have mentioned in the bracket so that you don't get confused, because brachytherapy is a method of giving radiation. Brachy is from inside, tele from far, television like, okay. From far if you give radiation, teletherapy. So chemoradiation is the management for this patient. Now you can take this picture here, and this is all what is given in Novice Gynecology, a good amalgamation of the information that if a person is having CS cervix, what all options you have. Now 3 mm no lymph vascular space invasion, LVSI, we can just do conization or a simple hysterectomy and the cancer is taken care of. But remember, we have some women who would want to save the uterus because they are young in spite of having lymph vascular space invasion. Let's see, less than 3 mm depth of invasion, but lymph vascular space invasion is there, but the invasion is very less. We can do a radical tracheolectomy, that is just taking out the cervix and saving the uterus. You can do radical hysterectomy if she doesn't want the uterus, but we can save the uterus. Now see, 1A2, 1B1, in both of these also we can save the uterus. So where we cannot save the uterus is when the lesion is more than 2 centimeters. When the lesion is more than 2 centimeters, we cannot save uterus. We may have to do a hysterectomy. So yes, 1B2 onwards, hysterectomy comes in, and see the specific treatment I am telling you now, but the gross, remember these two lines, mostly these questions are coming. But yes, if you want to save the uterus, the lesion should be less than 2 centimeters. Now, any lesion which is more than 4 centimeters, so again surgery is not going to be enough. You may add radiation to it and chemotherapy. So anything more than 4, I told you the gross management, but remember even 1B3, we have to say that it's a growth more than 4 centimeters. So chemotherapy and radiotherapy is the best option. So to the rule which I gave you, there are some exceptions. So less than 2 centimeters till here, we can try and do a radical tracheolectomy and save the uterus. All right, let's move on. A third gravida, 2 abortion patient who previously had 2 midterm abortions, has a cervix of 15 millimeters length. On per vaginal exam, I think this is a repeat. I should have deleted that. We've done this discussion. Let's move on. Of the marked arteries, which is the one ligated when an internal iliac artery ligation is planned for a non-responsive to pharmacological management PPH patient? Okay, we are trying to say that we are having a patient with PPH who's had all the drugs given, pharmacological drugs which we discussed in the class earlier, and now nothing is working. So we think in terms of internal iliac artery ligation. It was a very simple topic earlier, but remember in PrepLadder, we always teach you in great details, and all my classes have taught you that we must always tie which part of the internal iliac artery, because there's an anterior part and a posterior part. Okay, so you know the branches, you know the mnemonic, how to remember the branches. You know the posterior division is only 3 branches. If I can tell you, see here, the posterior division, iliolumbar, superior gluteal and lateral sacral. So my mnemonic is short gills, that is superior gluteal, iliolumbar, lateral sacral. So that's my mnemonic to remember, and what is not in these 3 is antidivision branches. So that was the usual trick. You may have your own interest in mnemonics, I know, but that's the usual trick to remember the branches of anterior and posterior division. The examiners have moved, they've moved much beyond that now. They're asking you questions which are asked even in the MCA exam and the PG entrance exam. For the last 4 exams, for 4 exams, not 4 years, last 4 exams, they've been asking you about the internal iliac artery. So yes, if you see the internal iliac artery, A, B, C, D, which one are you going to ligate? See, common iliac artery splits into internal, external. Internal splits into anterior and posterior. Anterior's major artery which we are discussing in PPH is the uterine artery, and it comes from the anterior division. See this one, the anterior division here. This is the uterine artery. So if I am going to do the ligation of the artery, I am going to do the part which is going to the uterus. So uterine artery we ligate, doesn't work, we go and ligate the anterior division of the internal iliac artery ligation we do. Okay, so the ligation is done here. Now we do not do a ligation of the posterior division because that's nothing to do with the uterine blood flow. So MCQ question asked a few months back, if you do a ligation of the posterior division by mistake, superior gluteal artery, the major blood vessels to the gluteus maximus and also to the sciatic artery, the patient, if you do this ligation, the patient may present to you with gluteal pain if you've done this wrong ligation. That was the MCQ. So if you know the basics and you know that we ligate only the anterior division, and the question is, after internal iliac artery ligation, a patient presents with gluteal pain, what branch would have been ligated by mistake? So it's the posterior division artery was the answer. So if you know the basics, then only you can answer that. There's another basic which is important, that when we're doing the ligation of the anterior division also, that is the place to do anterior division. When we're doing this ligation, it is just a, if this is the artery, it is just a snug ligature. It is just a snug ligature to reduce the pulse pressure, to reduce the flow. We are not doing a total obliteration of the anterior division. We are not just squeezing the hell out of it. We are not doing that at all. So yes, we are, by this internal iliac artery ligation business which we are discussing, we are reducing the pulse pressure so that the flow is now sluggish flow, and that sluggish flow promotes thrombosis. Okay, fine. So that's the principle of internal iliac artery ligation, that we are promoting thrombosis in the uterine bed, that is the placental bed where the bleeding is happening. All right. So whole lot of discussion about this is there in your exams these days. Do read about this with a renewed vigor. All right. Let's move on. A para 1 live and woman presents at 12 weeks postnatal with irregular bleeding since 1 week. 1 delivery, baby is live. She presents at 12 weeks with irregular bleeding. Around 12 weeks of bleeding we think in terms of secondary PPH, and secondary PPH is because of retained bits of placenta. Correct. But the next line, she underwent a DNC at a private hospital 1 week back. Already taken care of. You thought of retained bits of placenta, they've already taken it off. Now, what could be the likely cause of this bleeding now? In spite of, she's having secondary PPH, you thought, in spite of ruling out retained bits, that is, you've taken them out already, somebody's done a surgery, assuming that he's a good surgeon or she's a good surgeon, both types of gynecologists are around now. So, assuming that a good surgery has been done and retained bit has been removed, but still she is bleeding, what could be the cause? She has started her periods? Not likely. Within 1 week, she will not have periods. Least likely. Retained bits of placenta? No, we've already removed them. It's normal bleeding. No. Lochia, no. I will not say lochia at all, because lochia upper limit, is 35 to 36 days of delivery. So this is 12 weeks. So around, maybe you can say 4 to 5 weeks lochia can stay, that is the upper limit, mostly around 2 to 3 weeks it is there. So if it is 35, 36 days, I would have still thought of that, but this is not lochia. So yes, is it a neoplasm? Is it a gestation trophoblastic neoplasm? Maybe the choice should have been persistent trophoblastic disease. Whether it's a neoplasm of which type, that may take a tissue biopsy for you to be very sure. So I would say persistent trophoblastic disease, or you can say gestation trophoblastic neoplasm. That is likely the cause here. Okay. So trophoblastic conditions, all of you know the trophoblastic conditions. All of us know that the vesicular mole can cause a choriocarcinoma because of persistence of trophoblastic tissues. So vesicular mole can cause a choriocarcinoma, okay, but remember that also a normal pregnancy has trophoblast and an abortion also has trophoblast. So these can also cause the persistence and choriocarcinoma. In fact, you know that it's not only choriocarcinoma they can cause a invasive mole also, and it can also cause a placental site trophoblastic tumor. I am writing just tropho here, okay, this trophoblastic tumor obviously. So yes, you must know this chart. I am sure you knew it also, but then for a quick revision for everybody. So normal pregnancy, vesicular mole, abortion, these are the benign trophoblastic conditions, and invasive mole, choriocarcinoma, placental trophoblastic tumors, these are the gestational trophoblastic neoplasms. Okay. Now, invasive mole is most common result of these three, most common persistent trophoblastic disease, and remember, it does not follow a normal pregnancy. Yes, you know rules in medicine, but those who know the exception to the rules, they get better marks. So exception to the rule is that all these three can become these three, except normal pregnancy does not follow invasive mole. I mean, invasive mole doesn't follow normal pregnancy. Now, invasive mole, you will see only locally invasive tumor. So chemotherapy doesn't reach it too well. So treatment is mostly by surgery. RX is SX, okay, SX for surgery. Choriocarcinoma, very good treatment with chemotherapy. In fact, chemotherapy is so good that suppose a young woman, say, we can do surgery, let's say after 40 years when the uterine purpose is over and she's got a cancer, I can do a hysterectomy also. But chemotherapy has got such good results. This chemotherapy has such good results that a woman with choriocarcinoma, let's say she's 25 and I give her chemotherapy, let's say methotrexate or MAC regime or the EMAC or whatever, the chemotherapy is so good that the choriocarcinoma totally vanishes, and women can actually use the uterus for a normal pregnancy after some months. So remember, chemotherapy, best treatment for choriocarcinoma, especially with young women, and methotrexate based chemotherapy. Placental trophoblastic tumor, this one is also surgical treatment. But what is the MCQ which came in the AIIMS exam a few years back, that invasive mole HCG will be high, choriocarcinoma HCG will be high. So these are used for the follow up, but placental site trophoblastic tumor is by the cytotrophoblast, and that increases the HPL. So placental site trophoblastic tumor, the follow up tool is not HCG, it is human placental lactogen, okay, because it's from the cytotrophoblast. I cannot resist but give you this, you can't see me, is it? All right. I don't know. I said what is behind my head is cytotrophoblast, and it increases the human placental lactogen. Okay, I don't think I can. Okay, yeah, now I think you saw it. Okay, so sorry for writing on the corners. Okay, A 36 weeks pregnant woman presents for antenatal evaluation. She is adapting with sugars control on diet. Okay, 36 weeks, diabetic. Sugar control on diet, and NST done at the visit is non-reactive. Non-reactive NST. What do you do generally when there's a NST non-reactive? Tell her to have food, and the food will make the baby move. The sugars increase, baby is very happy. But here we've asked you a trick question. She is already adaptic, so don't think of food. She could be in a condition where the baby is very sick because of her diabetes. Okay, diabetes is a little different. So when a person is having an NST non-reactive because she is a diabetic, which of the following is the most relevant next step? Now don't say repeat the NST after a meal. That is for regular women whose NST, no problems otherwise, NST non-reactive because the baby is sleeping. Give some food to the mother, baby moves, do the repeat NST. Here she is adaptic and she may be having high sugars, and the problems could be ketoacidosis, and the baby is actually very sick, and you give more sugars, you make things worse. So the next step is, don't induce 36 weeks. Try to see what's the cause. LACS, just not yet. Do an ST after 1 hour. I warned you against this one. Do a biophysical profile. Now that's the answer for this variation. NST non-reactive, we do a repeat one after a meal. But this is non-reactive in adaptic. Do a biophysical profile immediately and see if all the other parameters are fine. Okay. So yes, a 26-year-old primary gravid at term gestation presents with labor pains. On vaginal examination, cervical dilatation is 4 centimeters, 60% effaced, and the liquor is meconium stained. Fetal heart rate is 92 beats per minute on 3 occasions in the last 30 minutes. You know, anything less than 110 is bad news. It is fetal distress. So last 30 minutes, the heart rate is dipping to up to 90, 92. Which of the following is the most appropriate management? Meconium staining of liquor. Okay, that is, there is some stools in the liquor, and when the baby is born, we are worried that may be having a meconium aspiration. Now, what do you do in this condition when the heart rate is 92 at 4 centimeters 92? Oxytocin drip to accelerate labor pains at 92 and 4 centimeters. It is going to take at least 6 hours. I mean, it's a primary gravid, it may take even more time. Okay, it's going to take at least 6 hours. Now, on occasions, it's been 92. So yes, do not increase the labor pains. It's not going to be any benefit because it's going to take time to deliver. IV drotavir to improve cervical dilatation, it's a doubtful usage in the first place to dilate the cervix. Okay, so it's not going to work so fast that the cervix is going to become immediately 10 centimeters. Attempt a vacuum delivery, please don't. You will injure the baby, you will injure the cervix, you will tear the ligaments, you will tear the vagina and cause massive hemorrhage. Don't do all this. Only after 6 centimeters theoretically. Generally around 8-9 centimeters only we do vacuum. Fully dilated, definitely. After 8-9 you can theoretically put it, although the limit is more than 6 centimeters. I know you are going to say 6, but yes, around 8-9 only try vacuum. Okay. So start oxytocin and shift to OT for an emergency cesarean section. Now please, I'm that one proponent who always talks about breech vaginal delivery and vaginal birth after cesarean and all those things, but when there is fetal distress, I don't talk normal, I talk cesarean. Fetal distress 4 centimeters, please go ahead and do a cesarean. Answer over. This question answer is fetal distress and cesarean section. For fetal distress, cesarean section. Now please, the answer is cesarean section for fetal distress, not for meconium staining of liquor. Now that's where you guys are wrong. MSL, meconium staining of liquor, is often used as indication for cesarean section in quite a few practices, and that's not correct. Thick pasty meconium and that is not getting diluted, maybe we can think, but meconium staining happens to so many pregnancies and that's not an indication of cesarean. It's an indication for you to give amnio infusion, give some amniotic, give some normal saline through the vagina, put a catheter into the uterine body above the head of the baby and give some warm normal saline inside and dilute the meconium. Okay, dilute the liquor so that meconium is not so thick, and when the baby delivers, there will not be much problem with the aspiration, if at all it happens. It's not that there is meconium aspiration and he will definitely aspirate. Please, if he aspirates with meconium, we know that that can be a problem, but that is not going to happen every time. If at all it happens, you already diluted the liquor by giving amnio infusion. So yes, I would say meconium stained liquor is not a straightforward indication for cesarean. The indication in this example is fetal distress. Now, another thing which you people always keep falling for, and that is the cord around the neck. Cord around the neck at delivery. Please go, and YouTube is full of people who delivered with a cord around the neck. You will see so many deliveries being shown with cord around the neck. Please, cord around the neck is no indication again for cesarean section. I know some gynecologists, you know, I mean, I'm not saying that everybody does that, but yes, some people are on a short fuse for cesarean sections, and they say, "Oi, the ultrasound is showing a cord around the neck." So what? Cord can be around the leg also, it can be around the abdomen, it can be around, you know, any part of the body. So cord at any place, what is going to do? It is going to, the cord is going to be around the neck, so the neck is going to get squeezed. So baby is inside the uterus. If the neck is squeezed a little bit, I mean, it's not going to be like a, you know, he's not going to get hanged on his cord. He's inside the abdomen, inside the uterus of the mother. The cord is having a loop around the neck, fine. Cord can be looped around so many other parts. And the cord has Wharton's jelly. There is so much of Wharton's jelly in the cord. The cord is having so much of protection. So this cord, even if it is looped, there is so much of Wharton's jelly here. And then through that, the vessels are going like this. So even if it gets looped around the neck and gets a little compressed, the blood flow is not compromised at all. So there is no problem to the blood supply to the baby. No sir, we are not talking about the blood supply to the baby. We are talking that the cord is around the neck, it's going to squeeze the neck and the baby won't be able to breathe. He's anyway not breathing inside the uterus. From his mouth he's not breathing, from his nose and mouth he's not breathing. He's breathing through the umbilicus, through the cord. So the cord around the neck does not squeeze the cord, and it does not cause any distress to the baby. It does not squeeze the neck of the baby. Please, cord around the neck is no indication of cesarean, for God's sakes. And recently I don't know why I have not got the permission from my friend. I recently delivered a friend who had a cord around the neck, and I can just say that's a doctor friend. And when she delivered, there was a cord around the neck, and she said, I must have a cesarean. I said, no, please wait. And this happened around 20 days back. I'm going to get a permission from her, and I'm going to show you that video on one of these forums, okay? It's going to be shown to you so that you get convinced. Okay, let's move on. A primary gravido underwent a normal vaginal delivery by an intern. That question came, okay? I have not made this question. This phrase intern was there. I'm so sorry. That's National Board for you. It came in the MCI exam. A primary gravido went, they could have written an untrained person, maybe they could have written that. A primary gravido underwent a normal vaginal delivery by an intern. Patient had minimal bleeding but an out of proportion shock, and eventually she died. What is the cause of the death? Right? Minimal bleeding, out of proportion shock. So the bleeding is not much, but there is a shock. So yes, the intern part is not very important in this, because if the primary gravido underwent labor, so uterine rupture is out. Bleeding was minimal, so PPH is out. So yes, maybe the intern was not very careful and he pulled the cord without giving counter traction. I doubt, you know, today's interns are listening to so many of lectures in so many forums, so many institutes, and the only thing they know is active management of the third stage of labor, and the only thing everybody agrees is the control cord traction. So I really didn't like that intern part here. So anyway, so he did a control cord traction, then nothing would have happened. But maybe this intern was not very aware of what to do, and he pulled on the cord, and when he pulled on the cord, the plaster which was attached to the fundus here like this, and when he pulled on the cord, he got the uterus to get inverted. Now that's my first diagnosis here. Yes, in this inversion of uterus, the baby can die. Inversion of uterus, okay, inversion of uterus, the baby can die with neurogenic shock and hemorrhagic shock. S for shock, I'm so sorry. Okay, neurogenic shock and a hemorrhagic shock. Which is the most common cause of death in a inversion? It is actually the hemorrhagic shock. The most common cause is the hemorrhagic shock. Neurogenic shock is actually the pain. The pain can kill. So yes, the more common likelihood is that the intern delivered the baby and the cord was pulled and the inversion happened and the neurogenic shock killed the mother. because they're saying there is minimal bleeding. So I can't say it was the hemorrhagic shock. Either way, it is inversion which has killed the baby, and that is because of the neurogenic shock, although the more common cause is the hemorrhagic shock. Now some of you must be already writing, why not amniotic fluid embolism? Nobody's writing that? Okay, fine. Some of you written, Dr. Zoyatran, yes, she's written that it is hemorrhagic shock. Yes, I'm happy that you agree with me. But the bleeding was minimal. So yes, it is inversion with probably a neurogenic shock. It can be amniotic fluid embolism, but it is very rare. It is one in, around, in India, it is not the commonest cause. It is like the chances, we say it's one in, 20 to 50,000 deliveries, that we don't say amniotic fluid embolism happens so commonly in our country. It happens, but PPH kills so many more that we don't think of amniotic fluid embolism as a common cause. So that's why it's a little underreported. The woman bleeds, and we know that most women bleed in our country and they die. We think it is PPH. Actually, they could have died because of amniotic fluid embolism. So it's a little underreported, but yes, it's not so common at all. But yes, mortality is more than 30% with amniotic fluid embolism. That you must remember. Okay. So yes, inversion with a neurogenic shock or a hemorrhagic shock is the likely cause. They have written minimal bleeding, so I am saying neurogenic shock. Right. A woman who delivered a week back complains of crampy pain in the abdomen during breastfeeding. Every time she feeds, there is crampy pain. Which of the following is the likely reason for the cramps? So yes, that's a very simple question, just that you remember what is happening here. Why is there crampy pain? We know that after the delivery, the uterus is at the level of the umbilicus. Just after the delivery, uterus is here, and then it slowly keeps involuting. It slowly keeps coming down. So the rate of involution is at 1.5 to 2 centimeters per day. And this involution, the uterus going down, is aided by the maternal oxytocin. And every time the mother feeds the child, every time the baby suckles on the breast, oxytocin is released. That oxytocin is going to cause the milk letdown. It is going to cause the milk letdown, but it is also going to contract the uterus and help in the involution. So that contraction is going to cause a crampy pain when she breastfeeds. So yes, this uterus will become a pelvic organ. It will become a pelvic organ in around 4 to 6 weeks. It will become a normal, I'm so sorry, in a hurry I think. So sorry guys. It is a pelvic organ in 2 weeks and a normal organ, this one, in normal organ in 4 to 6 weeks. Apologies for the mistake. So 2 weeks it becomes a pelvic organ and it becomes a normal organ in 4 weeks or up to 6 weeks. Alright, so the answer to this question is oxytocin. Now identify this pattern during cardiotocographic monitoring of a high risk pregnancy. Cardio-toco. Now please do not equate NST with CTG. Now that's where you're wrong, okay? NST is not the same as CTG. NST is one probe just seeing the fetal heart rate. Cardiotocography, we see the toco. You know what is toco? Uterine contraction. We measure the uterine contraction and we measure the fetal heart rate. So there are two things we're measuring in the cardiotocography. So CTG is not equal to NST. It is used, a lot of you when you're doing NST for pregnant women in the OPD, you keep saying CTG. A lot of us doctors are the culprits because we say, yaar uska get the CTG done. That's not the right thing to say, okay? CTG is in labor, cardio-toco. Toco means contraction. So cardiography and tocography together. That is what is two probes. You'll see a picture. That was an image-based question for you some times back, that there's a probe on the tummy on this side, another probe here. So there are two probes one is taking the fetal heart rate, other is taking the uterine contraction. So the fetal heart rate in relation to the uterine contraction, both we make a graph. So yes, in this picture you can see there's the fetal heart rate here and the tocography here. So with the uterine contraction, can you see the peak is here, the heart rate is going down much later. So that is why we call it a late deceleration. See, it's a classical late deceleration of a patient in my hospital. Around a year back, I got this picture from the CTG which we did in the labor room, and we see this so many times, but to get the right picture at the right time is the question. So yes, that is a late deceleration, okay. And early deceleration, of course, it would happen something like this, early deceleration, if I draw here and tell you, with the peak of the contraction, the lowest heart rate. So, these coincide, that is what is early deceleration. And variable deceleration, see, variable length of deceleration, this is this much, this is longer, this is even longer, umbilical cord compression. So, cord compression causes the variable deceleration. This is the most common deceleration. Variable deceleration is most common. Mostly it is normal. Almost all the time it is normal. Okay, fine, I'll say that. Almost all the time variable deceleration is normal. And early deceleration is absolutely normal. It is because of head compression. But the late deceleration, the one which I am showing you here, is not normal. Mostly these women have to have more surveillance in this time of delivery, and they most of the times end up in cesarean sections. A 28-year-old graduate to Para 1 presents at 26 weeks in antenatal OPD. She's had a history of previous preterm birth at 28 weeks. The previous baby did not survive because of prematurity. Which of the following alphabet type sequence of change in the internal os could have been seen on the ultrasound while she progressed to preterm labor? I think you know this question already, because they are trying to tell you that there was a preterm labor last time, and if you were smart enough to do an antenatal ultrasound before the preterm labor, if you were doing ultrasounds regularly, you could have seen some changes in the cervix, that the cervix could be opening a little at the internal os. So, if you see this picture of the internal os here, it is a tightly closed internal os. This is the internal os, this is the external os. Now, if this internal os is opening up a little, this internal os is now funneling inside, okay. There is a funneling inside. So, that means if this is seen, then you will tell the mother that you are going into some changes, you may have preterm labor. This is the earliest sign, funneling, okay. So, yes, what is the progressing of events when there is funneling? So, yes, first it becomes like this, the one which I showed you, Y shaped like this, then becomes a V shaped, then a U shaped. It is usually a T shaped. So, yes, Y, V, U. I think B is the answer from my side. I am just showing you all of that with a picture which I drew before to save time with you guys. So, yes, this is the T shaped cervix, okay. Maybe I should have drawn the T a little bit more convincing. Okay, fine, I did that now, okay. And then there can be a Y shaped cervix here, this one, V shaped cervix here, and a U shaped cervix here, okay. So, if you see a U shaped cervix, this is imminent, delivery. She is about to deliver just now. Now, Y shaped is sometimes asked, what is the first sign? The same question can be asked in a different way, that what is the progression of these alphabets which you see, Y, V, U. Which is the first sign you see? This is the first sign, the Y shaped cervix, first funneling in a Y shape is the first sign most of the times, all right. So, the next question is, a 23-year-old primary graduate presents with pain abdomen at 2 weeks overdue, I am so sorry. A 23-year-old primary graduate presents with pain abdomen at 2 weeks overdue, that is beyond her previous date. She has missed her dates by 2 weeks. So, roughly around 5.5 weeks, 6 weeks of pregnancy. Ultrasound shows a 2.5 centimeter gestation sac in the left tube. Of all the following drugs may be used for the medical management of this patient except. So, yes, if I want to do a medical management, okay, there is an ectopic pregnancy. Remember, we can never save an ectopic pregnancy, okay. I know you know that, you know that very well, and there is no point discussing that can we put this baby into the uterine cavity, all that is nonsense, okay. This baby, if you save it, he is going to kill the mother. So, this baby has to go. So, death of this baby is the saving of the mother. So, medical abortion, medical treatment and surgical treatment is the management. Medical can be done by so many drugs like potassium chloride, methotrexate and mifepristone, but never mesoprostol, right. This mesoprostol is going to cause a lot of contractions, and those, okay, I will show you with the hand, is going to cause a lot of contractions, and those contractions, if you see, those contractions will push out the baby. Yes, it can push out, but it can also rupture the tube. So, that is why we do not say in terms of Mesoprostol at all. So it was used, it was controversial, so we don't talk of it. Mifepristone not also the very favorite drug for medical management. So potassium chloride, methotrexate, actinomycin, these are the drugs which are generally used for medical management. So when do we decide? When we decide for medical management and surgical management, the criteria all of you know very well, but a quick revision doesn't hurt. If the size is 4 centimeters, less than 4 medical, more than 4 surgical. If the HCG value is 5000 international units, less and more. Less than 5000 medical, more than 5000 surgical. And the cardiac activity is absent, I can do medical. If it is present, I'll have to do surgical. So medical, surgical based on these parameters. This is what is given in NOACS gynecology now. These are the values, this 5000 value, this is what I have been teaching ever since I started teaching many years back. But remember, the value some people use is 3000, some people use even 10,000. I know of people who manage pregnancies by medical methods even at 20,000 and they don't work. They cause severe side effects. So the value which has given us best results is 5000 and less you do medical management. 3000 less is playing it very safe. More than 5000 playing it dangerously. So what has research shown us? 5000. So that's what I have been always saying as the answer, and now in the latest NOACS, the 2020 edition, they have mentioned 5000 as the value in a tabulated column. If you want, you can have a look. So yes, medical management, surgical management. Now the surgical management which is best is the linear salpingostomy. So if you can see the fallopian tube like this fallopian tube here on the, if my knuckle of my finger is the ectopic bulge, I make an incision here with the blade, you know, a linear salpingostomy. I make an incision like this, a linear salpingostomy. Open the tube, take the baby out, leave it just like that. Don't suture, not required. Make an incision, take the baby out. Of course, get hemostasis done and then leave it open. It will close by itself in 24. Reperitonealization of viscera can happen in 24 hours to 48 hours. It will close properly in that time. So please remember, linear salpingostomy, not gotomy, okay? Don't say that. So the surgical procedure of choice, I'll just write here, just one thing I thought I can say there, linear salpingostomy, okay, right. Primary gravidae presents with spotting in right-sided flank pain. She has had a serum beta HCG of 880 milli-international units 3 weeks ago. Ultrasound does not identify an intrauterine pregnancy. A diagnostic laparoscopy revealed 125 ml of blood in the pelvis. A placental tissue is recovered floating free in the peritoneal cavity. The pregnancy is likely which of the following? Okay, the woman is having pain abdomen. The beta HCG 3 weeks back was around 880 and there is nothing in the uterus. When I did a laparoscopy, I saw some blood around 125. Placental tissue is recovered in this blood floating free. How does placental tissue come into the abdominal cavity? It has to be a rupture uterus, which they are not suggesting, and it's a very early 880 will never erupt. That is a small sac wherever it was. It is not going to cause a rupture. It may come from the fallopian tube if the tube has expelled a baby. Just now I was showing, you know, this tube peristalsis can expel a baby. So that's what is known as a tubal abortion. So spontaneous abortion, that happens outside the uterus. So spontaneous abortion is something else. Spontaneous abortion is here. Look, the baby is here, that is ectopic. If the baby is here and it goes out, that is what is spontaneous abortion. If the baby comes out here, that's a tubal abortion. So that's the difference, guys. So what we are saying, that this baby comes out, I don't think then there will be trophoblast in the peritoneal cavity if this is the condition. So yes, from the tube if the baby comes out, so this placental tissue, the trophoblastic tissues might be seen in the blood, floating into the blood. So yes, it's a tubal abortion. Decidual cast, this is the decidua here, okay. I'll draw with another color here. This is the decidua. The lining of the uterus is known as endometrium. Lining of the uterus in pregnancy, decidua. So that decidua can come out, but not inside the uterus. So it's not the decidua, it's definitely not endometriosis, okay. So let's see another thing. A woman presents with irregular bleeding and a raised HCG. Ultrasound and biopsy confirm a diagnosis of gestation trophoblastic neoplasia. An antecedent pregnancy of which of the following types carries the highest risk of mortality? Now, the same question which we discussed a little while back, a woman is having a gestation trophoblastic neoplasia because the HCG is high after a normal delivery. After normal delivery, the HCG should be going low, okay? Now, the HCG is high, that means persistence of trophoblastic tissues, the diagram which I made. It can follow normal pregnancy, I already told you. Antecedent pregnancy of which of the following carries a higher risk of mortality? That means the picture which I showed you there. I'll just revise. Choriocarcinoma, I told you, can follow three things. Just an abridged version of that diagram there. It can follow a vesicular mole, it can follow an abortion, it can follow a normal pregnancy. This is less than 1%. This is up to 20%, this is less than 1%, this is less than 1%. But yes, when a choriocarcinoma follows a normal pregnancy, it is the worst prognosis. So, what diagram I showed you there? This is the gist of that, and when a choriocarcinoma follows a normal pregnancy, it is the worst type of choriocarcinoma. So, that is the MCQ here. A full term pregnancy and then a choriocarcinoma is a bad news because HCG is high for a long time. That is why the effects of HCG and the proliferation of trophoblastic tissues is much higher with a normal pregnancy. Okay. So, this is the WHO prognostic scoring, all right. The PG entrance students, maybe the students who are writing the entrance for MCI, they do not have to know this in great detail just as yet, but next year definitely it is going to be creating a trouble for you. So, yes, the WHO prognostic scoring is antecedent pregnancy, higher form mole, abortion, term. See, this is how we make the scoring. If it is a term pregnancy, look, there are so many factors there, around 9 factors are there. So, these factors all together, we take a WHO prognostic scoring and say high risk or low risk. A low risk is anything less than 7, okay, and a high risk is more than 7. So, more than or equal to 7 is high risk, 6 and less is low score. So, less than 7 they said, not less than or equal to, 6 and less. Either you can say less than or equal to 6 and more than or equal to 7. That would have been easier, okay. So, 6 and less is low, 7 more is high risk. How is that score derived? It is derived based on this full-fledged WHO scoring system. Now, in this WHO scoring system, remember, a normal pregnancy, term pregnancy gives more points, so worse prognosis. So, you must remember that the number of metastasis, size of metastasis, more metastasis, metastasis to brain, liver, okay, and blood group, all of these factors will increase the score, okay. And metastasis to the brain is worse news. Metastasis to lung, see, is it even mentioned here? It is not even mentioned, because that is primary metastatic site. So, when the lung goes, lung involves with metastasis, when the trophoblastic tissues goes to the lung, it is the primary metastatic site. So, the stage is also stage 3, anything else is stage 4. So, when the tissues reach the lung, it is not as bad as tissues reaching the brain. So, please understand, involvement of the lung does not mean that you have to give the highest grade of chemotherapy. That is why I was trying to tell you a little bit about the WHO prognostic scoring. So, what was the question here? What is the worst pregnancy which can give a bad choriocarcinoma? That is a normal pregnancy, worst type of choriocarcinoma, worst predisposing pregnancy, normal pregnancy. Now, the question asked sometimes is, what decides whether you should give single agent or multiple agent or an extended chemotherapy, that is low risk or high risk? How do you do that? With this. Next information, very important for PG entrance students, that the scoring of stage 1 disease, there are 4 stages, 1, 2, 3 and 4. 1 is always low risk, stage 4 is always high risk, and stage 2 and 3. Stage 2 and 3, This risk assessment is based on this WHO prognostic scoring system. Stage 2 and 3 is based on this prognostic scoring system. Let's see one more question to have the more deeper understanding of what I just said. A 32-year-old female presents to the hospital with cannonball appearance on the chest X-ray. Question which came in your NEET exam just now. 32-year-old female presents to the hospital with cannonball appearance on the chest X-ray. Patient had a history of molar evacuation. Which of the following is the best management? That is, she's got a metastasis to the lung after molar pregnancy was evacuated. So, is it a high risk or a low risk? Only this much information, nothing else given to you. And the primary metastatic site is the lung, which is not even mentioned in this scoring. This is spleen, kidney, GI tract, brain and liver. So, lung is low risk. That's all. When the lung is low risk, although it is stage 3, now you will get confused here. That's why you got some wrong answers here and there. So, lung is stage 3, I just now told you, but it is a primary metastatic site. So, only in 2 and 3 stage you have to say low risk or high risk, because stage 1 is low risk, stage 4 is high risk. Now, 2 and 3, whether it's low risk or high risk, WHO prognostic scoring. Now, they said just a little bit information that from the molar pregnancy it's gone to the lung, nothing else. So, it's low risk. I'll give only single agent chemotherapy. All right. So, single agent chemotherapy is more than enough. Okay, you don't have to give the extended chemotherapy. Right. So, stage 1 disease usually has a low risk. Those with stage 4 disease have a high risk score. The distinction between low risk and high risk applies mainly to patients with stage 2 and stage 3 based on the WHO prognostic scoring system, and high risk GTN will require combination chemotherapy. So, this is that screen which you should save so that you don't have a confusion when you are answering questions like this. It's a very no, I'll not say it is simple. It is something which requires some attention from you people, because you know, south of India, all my friends from which part of the country which is below Nagpur, you know, only rice eaters. Unfortunately, Southeast Asia, south of India, rice eaters, more cholecarcinoma, more H-mole. So, we have seen so much of this that you have to understand that this disease, read it from the South Indians. If you have friends who are in the south and you are in the north, just ring them up, and these interns would have seen some of these cases there and they can help you. So, yes, these interns are giving chemotherapies because there is so much of cholecarcinoma happening in the south more than the north. So, I am not trying to do a divide here, guys, please don't get me wrong, but please just call them up and see, they will tell you that yes, we see vesicular mole, we see cholecarcinoma so many times, we give chemotherapy. Here in the north it becomes a little rarity to see, but please remember that cholecarcinoma, the worst is after the normal pregnancy, and high HCG and number of metastases and the ones involving the brain and the liver. Lung is the the least of the problems. Going to the lung is stage 3, but it is low risk. All right. Instrument shown been applied at the end of this video. Okay, I think I have to play this video so that you'll understand this. What is the instrument shown which is applied at the end of this video? I should have been you can see they are showing an instrument which is applied at the end of this video. Okay, so not this one, this is something else. This is the end of the video. See, there is an instrument. Now you can see that instrument properly, and this has been applied here at the angle of the uterus. Yes, yeah, somebody said okay fine, that's the video Dr. Vij wants. I was making this video and my friend, she said okay fine, that's what he wants to see. Now what is this? What is this instrument? You want to see it again? Okay, right. See this once more. See, this is a flat instrument. Okay, okay. I'll try to show this again to you. Yeah, see that instrument. Now tell me what is the instrument which is applied at the angle of the uterus to control the bleeding from the angle of the uterus. So yes, most of you interns who have assisted in cesareans, you know that the senior resident applies a Alice forceps, but the ideal instrument is the green Armitage. Okay, green Armitage forceps. Green Armitage, that was a obstetrician, the British obstetrician who worked in British India, and he was an extremely good obstetrician who, he was a very regular worker, and after the partition, after the independence, he went back to London. He was one of the senior doctors of the Royal College, and he's the one who is credited very honored kind of obstetrician, and he was the one who made this instrument, the green Armitage. It's a flat instrument. See this one now. It's a flat instrument at the tip with horizontal serrations. So it does not hurt the uterine muscle, but it clamps the uterine artery and stops the bleeding very effectively. This is the instrument which you should be using. All of you who are going to become gynecologists, it's always there in the set. The nurses know this. The OT technicians know it. Only we gynecologists tend to take the shortcut and take the Alice, because the Alice forceps is always available. All right. So the Alice forceps is this one. This is the Alice forceps. Look at his tooth. The tooth forceps, if you use it, will hurt the muscle. It will make it bleed a little bit more. Yeah, it is used. What can I say? You people will not agree to me so well. But then yes, the ideal instrument to be used is this green Armitage forceps. All right. So yes, this is the green Armitage. This is the Alice, and we don't use the Alice. Now, instrument shown being applied at 6 o'clock position. Okay, this is 6 o'clock here. This instrument, I mean to say, what is this instrument? So again, we are trying to show you abdomen open in a transverse incision, and there's a big uterus here. They see, you can see the incision, the suture mark here. Okay, that's the lower segment. I think it's, you can make out that it's a cesarean which is just now closed. So what is the instrument which is used? To retract the lower abdominal wall and importantly the bladder. Yes, favorite instruments of the interns. All you interns who are stuck to the instrument, this instrument, and hanging to dear life with this instrument, because two gynecologists are busy operating and chatting with each other after the baby is out, and you are hanging for dear life. You want to go for your dinner, but that's how it is. You have to hold the retractor till the surgery is over. Now, what is this retractor? Your best friend, man. That is the Doyne's retractor. Yes, you know that very well. The Doyne's retractor is the one which is used for retracting the lower abdominal wall and the bladder along with this, so that we can do a lower segment incision. The bladder comes at the lower segment, isn't it? So push the bladder down, then only you can open the lower segment. Okay. So this is the Doyne's retractor. You know this one so well. Now this is the Deaver's retractor. There's a curved kind of a flat instrument which we use a lot in hysterectomies. It's because we operate in the depth. Pelvis is very deep when we open the abdomen. So it's a deep instrument. So we use the Deaver's retractor to cause this retraction. Okay. Now Journey's retractor. Journey's retractor is having these two spokes. So this is what is used for retracting the abdominal wall, skin retractor, and even the rectus retractor. This Journey's retractor is a good one for that. You've seen this one also. And Landon's retractor. This is actually a bladder retractor. The Landon's retractor is used for the bladder retraction while we're doing a surgery, abdominal surgery. It is also a retractor I use a lot when I'm doing a vaginal hysterectomy, retraction of the vaginal walls. We also call it a right angle retractor, but that is our derivation to call it the right angle retractor. This is basically the Landon's retractor for vaginal wall retraction, vaginal hysterectomies, and also when we are using to retract the bladder while doing the abdominal surgeries. Okay. While doing a vaginal hysterectomy also, people writing the PG entrance, when you read the steps of a vaginal hysterectomy, you know that there's a time when we reflect the bladder up, and now we're just cutting the uterus. So to keep the bladder in that place, again this is used. Okay. So abdominal surgeries and vaginal surgeries, both this is used, and both the times bladder retraction can be done by this very effectively. A gynecological surgeon performs and demonstrates application of B-Lynch hemostatic suture to his junior residents. The surgery being performed is, yes, now that's the easy one, B-Lynch hemostatic suture. They are asking questions, the same question in a different way. So yes, we are using it for a lower segment cesarean section, because sometimes the PPH does not just stop whatever you do. So before you go for doing internal iliac artery ligation or a hysterectomy even, we tighten up the uterus. This uterus which is so flabby, it is so flabby. I want that to become a nice tight contracted uterus like this, so that the bleeding stops. So I will put sutures like this, the B-Lynch hemostatic sutures. So yes, this B-Lynch hemostatic sutures, somewhat similar is the Heyman sutures also. They look like this. That's the picture. This is a case of a uterus which was bleeding a lot. In fact, this is a case of abruption. Can you see here? Can you see here the bruising of the uterus? That's a covalare uterus. So another information, covalare uterus in abruption have very poorly contracting uterine muscles. So labor is protracted, and after delivery P-pitch can also happen because uterus doesn't contract well. So this one, while we're doing a cesarean, she bled so much that we had to put stitches. This is the Beelan suture. Unfortunately, my resident was having a, this was a phone camera, and the camera lens was a little smudged, so not so clear, but I'm sure you could understand this. This sutures, the ones which like this. So this is the sutures here. Okay, identify this lesion. Is it a condylomata? No, it's not a wart. Is it a vulval hematoma? Is it a vulval cancer? No, cancers will have ulcers, especially vulval cancers. And Bartholin cyst. Bartholin cyst will be a little bit more medial around the opening of the vagina. So yes, this is indeed a case of vulval hematoma. Vulval hematoma can have something like 500 ml to 1.5 liters of blood sometimes inside, and all you will see is a small bulge like this. So please, those of you who've done deliveries and you've shifted the patient to the ward, you've checked the PV, you've checked the PR, everything you've done, but the patient is now collapsed in the ward, and you'll see a small hematoma. It's not so much, why did she collapse? You do a PV inside and see there's a huge bulge inside the vagina. That big bulge is because that the patient is having a vulval hematoma. Can be a problem. Give me a minute, please. Excuse me. Just a second, please. Don't go anywhere. Put this on charge. No, it's going on. And I want that back for the answers. I'm sorry, my phone just went off and I'm not able to see your comments. I'll just get it on back. So this is a case of a vulval hematoma. Okay. Now I'm showing you some more pictures. This is a vulval hematoma. Now look at this one. This is in line with the labia minora, and it's coming to the labia majora, and it is bulging into the vagina. Now this is a Bartholin cyst. Yes, it should have been classically Bartholin abscess is a little bit bigger and it might be having some discoloration, but this is a Bartholin cyst. And now look at this one. This vagina is, yes, there's rugosities, this lot of more folds in this. This is obviously old woman, and there's a small ulcer here. I don't know whether you could see that. Now there's an ulcer on the labia. Now this ulcer is probably a vulval ulcer, which I don't know whether it's a cancer or not, but this is how it comes. Okay, I'll just take it out again so that you can see. So this ulcer here. So vulval ulcer will mostly be on labia majora. Vulval cancer, they are asking you a little bit more than before now. Vulval cancer, you must read. We have discussed that in the app. And please remember that vulval cancer mostly starts in the labia majora 60% of times. 15% it may start even in the clitoris. So vulval cancer, most common presentation is itching, and mostly it is in older women. So the predisposing to vulval cancer is squamous metaplasia, lichen sclerosis. All right. So this is a vulval hematoma. This is a Bartholin cyst, and it can get infected also. The treatment of which is marsupialization, and this is a vulval ulcer. So before I take my the session off, and this is that one thing which I always feel that I should give you. This is the treatment of CA vulva, because I feel that some of you are having a little bit of confusion about CA vulva treatment and management. So just keep this slide. I'll not discuss about this. You just keep this slide and take the picture, so that you know that mostly we want to limit the morbidity of CA vulva. So how do I limit the morbidity of CA vulva? By reducing the surgery. And how I can reduce the surgery? By doing wide local excisions or just vulvectomy and not take out the lymph nodes. So how do I say that the lymph nodes can be avoided, the dissection, the extensive dissection of the inguinal lymph nodes and the femoral lymph nodes, and a still bigger incision on the vulva? How can we avoid that? We always say do a sentinel lymph node biopsy. A sentinel lymph node biopsy, and see if the sentinel lymph node biopsy is showing me involvement. We know that the sentinel lymph node, if there's an ulcer here and I put in a dye here, so let's say a methylene blue I put in here, this will go to the lymph node first. Which one? Maybe the inguinal or the femoral group of lymph nodes. So if this one has the cancer, this has the cancer, and the cancer is in this one also. See, the methylene blue tells me which lymph node to biopsy. I take this lymph node to the path lab and look under the microscope. This also has a cancer. We know that the cancer is spread to the lymph nodes. We have to do a much more advanced surgery. So that's all what I've mentioned in these protocols here. You must take these protocols, and I must now answer your questions, but unfortunately my phone got off. So give me that just one moment, okay? Please don't go away. I'm still here. Right, apologies for that. Okay. Bathlin. Right, Vivek, I'll see you soon. Hematoma, right? Something about hymen, bladder retraction, Babcock, OBGYN, 6 o'clock, OBGYN retractor. Hysterotomy. Can you see why it's not going down? That's all? No, there must be more. Connected. Acha, it doesn't go too far. Right, so whatever is there in the chat, live chat, I have seen. If it is, can you put the chat on? If there are some more questions, you can. If there are some fresh questions, you can ask me now, because the chat is not going much beyond the last 5 minutes. So if you have any fresh questions, you can send me immediately. I'll be around for another 5 minutes. All right, when I come to Hyderabad, I'll come soon. I'm sure I'll meet you, and thank you. Right, so that's the end of the questions, but then if you have any doubts, I'm still here for some more time. It was great. I mean, I thought I was not able to, I was sure that I'm not going to have a long discussion, but then I think I stretched you almost to 2.5 hours. So sorry for the longish session, but I thought I'll cover as many topics in as many details as possible. That was the idea behind that. So early cord clamping indication. Yes, early cord clamping is, yes, that's a good question, doctor. Early cord clamping I'll do when there is HIV. Okay, I don't want the infection. And yes, peripartum is the time. Hepatitis B does not transfer transplacentally. It goes only when there is delivery. So hepatitis, HIV, I'll do early clamping. I'll also do early cord clamping when there is a patient who is having a fetal distress, the baby is sick, mother is sick, RH isonization. Okay, good. Then thank you. Most common cause of post-menopausal bleeding, please, it is only C cervix, nothing else, guys. Okay. Motivational quote, read hard, read so hard that it hurts. Read till it hurts, okay? Please do that. Read till it hurts. And perfect practice. See, practice makes perfect, everybody says, but perfect practice makes perfect, okay? So do perfect practice, do a perfect reading, all right? Early cord clamping done. FMG topics are the same topics as the PG topics, all right? Please don't get confused. It's just that we are letting you go with a few easy questions. Now, please, MCI, do understand, all you people are getting some very tough questions these days. So don't think that your papers are going to be very much easier than the PG entrance. It's the same course, it's the same topics. Yeah, sometimes we don't ask you the intricate stuff like the advanced staging and the management staging wise. We'll ask you the gross treatment. But yes, that's where it stops. Most of you, please remember, you're writing the PG next year, aren't you? You're not just writing the MCI entrance, man. This is just the beginning of the questions and the beginning of the exams for you. So MCI guys, the best advice for you people, you're preparing for your PG entrance, okay? This is not the only exam you're writing. You're preparing for a PG entrance, aren't you? Okay? So yes, please read as hard as you can. Read for a PG entrance. MCI will happen on the way to the PG entrance, okay? Why is PrepLadder not on iOS? I'm already writing a message to my friends immediately after this. 3-4 people asked for this. Thank you for your comments. CS cervix, yes, CS cervix, no doubt about that. Length, rise, early cord clamping. Meconym aspiration, if it happens, yes, you will have to take the patient for, we'll have to manage the patient by suction and take the patient to the nursery and see for the effects of pneumonitis. If the baby is saturating well, we can manage without intubation most of the time, okay? But then see for the aspiration of chemical pneumonitis. So that's the problem with meconym aspiration. Baby can get very sick and the pediatricians will answer better, okay? Thank you for your remarks. Oh, that is such a nice one. Mary, somebody with Mary. Thank you so much. That was such a nice feedback coming. Thank you, seriously. Can you prepare, finish your FMG preparation 6 months? I think you can prepare in, if you're reading regularly, I say 3 months. I mean, like if you have done your MBBS with somewhat, some reading. But if you're very honest and you say, sir, I've not read in my MBBS, I passed somehow, now I want to do, then 3 to 4 months is more. 6 months is for people who are starting now. Those who have done some reading, 3 months is more than enough. And we have the PrepLadder rapid revision, and we have the notes for you people, so that when you can see the video and see the notes, then you can always correlate so much more better and faster. So those who have read a little bit also, 3 months should be the, and those 3 months, please, those 3 months read very hard. Give yourself that 6 to 7 hours of reading in a day, and that 6 to 7 hours should not be in a stretch. Give yourself 45-minute bursts. I always tell you that in the classes. 45-minute bursts, and in that 45 minutes, you must do a reading which is not interrupted by any goddamn thing in the world. Not your WhatsApp, not your food, not your friends, not the television, and not your parents. That 45 minutes, read so hard that if your next door neighbor gets bombed, you let him die, you do your reading. That's the kind of 45 minutes. Get up and discuss with your friends for the next 5-10 minutes. Go stroll around, have a glass of water, have a tea, another burst of 45 minutes. Give around some 5-6 bursts, 7 bursts of 45 minutes in a day. In those short bursts of 45 minutes, you will retain more than what you read for 10 hours to 12 hours sitting non-stop. All right? Right. So, great session. Thank you. I think we are mostly saying bye now. USP regime is for using combined oral contraceptive pills, and combined oral contraceptive pills you give 2 in the morning, 2 after 12 hours if they are 50 micrograms. If they are 30 micrograms or lesser, we give 4 pills now, 4 pills after 12 hours, and that causes a lot of vomiting. So USP regime, not the drug of choice. Best drug, emergency contraception, is equal to levonorgestrel pill, 1.5 milligrams. IUCD, most effective. Hello, IUCD, most effective. I did not say best. You cannot say, you cannot tell a woman that, okay, every time she has unplanned intercourse, we have to put an IUCD. Emergency conception works on the basis of over-the-counter drug. The woman has sex, she does not want to have a child, so she comes to the pharmacy, takes a pill and protect it. IUCD requires me to insert, it requires a gynecologist, it requires a prescription, and it's expensive. So it's not over the counter. So IUCD is for those people who don't come to you in the first 3 days. You know, it can be used for the 4th or the 5th day also. Why not for the 6th day? Because implantation happens on the 6th day. All right. Inversion of uterus, manual reposition, Dr. Nath. Manual reposition is the first one. The last part goes first, and then under general anesthesia. Okay? And of course, you can do hydrostatic reposition by warm fluids, and you can also do by surgical methods like Holstein and Huntington's. That we can't discuss. Tip for UPSC, clinical, read lot more, see lot more videos on YouTube, read lot more with PrepLadder, integrated teaching, PrepLadder, clinical discussions, see lot of these clinical situations which we are discussing with you. UPSC people are thoroughly clinical questions. They're asking only the clinical subjects. They're putting some anatomy and in some biochemistry in everything they ask. But yes, if you don't have a strong clinical backup, then UPSC becomes difficult. It's a good exam. Please write. UPSC is a good practice. Of course, you can have an excellent life if you're a UPSC doctor. Diploma in Obs and Gynae, Anuja. If you do MD, I'm happy. If you do DNB, I'm happy still. If you do DGO, you're compromising. So if you're getting an MD in anesthesia and a DGO in obstetrics, I would want you to take MD in anesthesia. Please, I'm very biased against DGO. I feel that I'm just not against the people. I'm so sorry if that sounded that way. I mean to say the people who diplomas are just as good, but you'll always feel that you should have done a MD. Or after diploma, you'll want to do a DNB anyway. So it doesn't stop at diploma. So if you're getting a DNB, even in forensic medicine or in biochemistry or in any other subject, you're getting a MD in, let's say, pathology, I would prefer you do that rather than doing a diploma in any subject. That's how I feel. You could say that I'm not correct and it's bad and I should chase my dream and do the subject I like, blah, blah, blah. So if you're doing diploma, then be ready to do a DNB, then maybe. Otherwise, if you're getting DNB and MD, go for that. COVID is not an indication for early camping. Good. COVID, there's no drug of choice. I'm sorry. Nobody knows the drug of choice even for non-pregnant people. So I'm the last person who can give that answer. Oh, wow. Thank you, Krish World and Dr. Right. Okay, I must, right. I've seen most of them and I think all the questions have been taken and I think we're having more of a chat than anything else. So I'll use this opportunity to thank you all for attending the discussions. Even if there were 5 students, I would have been satisfied, but I think there were more than 5 here. So I hope all of you learned well and all of you please understand that the impetus should be to understand a topic, not to do many MCQs. But yes, we do MCQs so that we know the topics which are coming. So if you understood the topic, any MCQ becomes easy. And all of you know that if you have all-round knowledge about that one topic, you can solve any MCQ which is coming. So don't get depressed if your guidebooks are not giving the correct language. What has been taught by us, 19 doctors in PrepLadder are teaching you. We're teaching you theory, we're giving you good MCQs. But sometimes you read some guidebooks and you get a little confused that the language was something else and the choice was not appropriate. That's because the questions are not recalled properly. A lot of guidebooks, a lot of doctors are putting their best to write guidebooks. They're all very hardworking people. But yes, the questions are recalled by people like you and me. So sometimes the questions are not in the best manner. So if the question is not making sense, forget it, move on. Just remember the topic. It is regularly coming as a question. Read the topic and move on to the next question. All right. So with this, I hope all of you keep reading very hard. And thanks for attending this session. May God bless you and all the best.